I am presenting a topic on magic of accordion maneuver in treatment of meta diphageal non-union humerus using Elizero ring fixator. I thank my mentor Dr. Jain Sharma sir for helping me out and making me understand the principles of Elizero. So, accordion maneuver is the bloodless stimulation of bone healing. It comprises of alternate compression and distraction, which converts the scar tissue at the fracture non-union site into tissues capable of new osteogenesis. Accordion actually is a free reed portable musical instrument, and the principles are based on this. So the concept was given by Sir Gabriel Elizero sir in his topic on clinical application of tension stress effect of limb lengthening. So the utility of accordion maneuver is mainly in cases of non-union, in cases of hypo-regenerate during bone transport, and in cases where docking site after acute docking or after internal bone transport. Coming to humerus non-union, the incidence is usually around 2 to 10% of cases, with the prevalence which is influenced by factors such as age, sex, comorbidities, and trauma mechanisms. It is usually higher in population with limited access to healthcare or in regions with higher rates of trauma. And it is more common in older individuals and patients with comorbidities like diabetes and osteoporosis. So it has a very significant impact on the quality of life of the patient, including pain, loss of function, psychological impact, financial burden on the patient, and various complications like infection, deformity, neurovascular injuries. Various causes of humerus non-union include severe trauma, inadequate initial fixation, infection, poor vascular supply to the bone, and certain patient factors like smoking and osteoporosis. So, various treatment options in cases of humerus non-union include surgical debridement and bone grafting with plating, external fixation, internal fixation with plates as well as screws, and intramedullary nailing. Certain bone stimulation techniques are also being used. So coming to accordion maneuver, this involves when we are going for distraction osteogenesis, there is a increased mechanical load which stimulates the mesenchymal stem cells, and it has different fields, osteogenic and chondrogenic field. So compressive forces may lead to fibrogenesis, osteogenesis, and intramembranous bone formation, while the distraction forces may lead to chondrogenesis and endochondral bone formation. So, as per a paper which was published in Journal of Limb Lengthening and Reconstruction in June 2018, so the protocol used for this maneuver is hypertrophic non-union, distraction followed by compression first, and in atrophic non-union, first compression, later on distraction. So, the principle is so 0.25 millimeter distraction or compression 4 times for 7 days initially, followed by rest for 3 to 4 days. Then the opposite maneuver again for 7 days, again rest for 3 to 4 days, and this cycle is repeated twice. And final compression is done at 2.25 millimeter every third day for at least a month. In cases of hyporegenerate, distraction is first discontinued, stability is assessed, then compression started, and assessment is done on the basis of X-ray, and later on distraction. Radiographic assessment usually done at monthly intervals till we see signs of union. Before fixator removal, dynamization should be done, and the clinical union is confirmed by absence of pain and weight bearing. Certain indications of accordion include aseptic non-union, segmental bone defects, failed various fixation attempts, and delayed union. So, I'm presenting a case of 45 years male who had a history of RTA, sustained fracture shaft humerus, in which plating was done. Post few weeks, patient started developing pus discharge, for which debridement was done. Still, infection persisted, so patient was operated using external fixator. Patient was even given a cast for that. Patient again developed infection. Patient was used with the ring fixator by using zero technique. And accordion maneuver was started using compression and distraction. So after a few months, we started seeing formation of callus. Okay. And then after removal of the fixator, we also gave a cast just for a temporary support. So I think not able to play the second video. Yes. So this was the movement after removal, and this was the skin condition. These are some other examples used in distal humerus and in stacked humerus as well. So these are various techniques of accordion maneuver which have been done by various surgeons, and various studies have been done on this. Certain complications include risk of neurovascular injuries, infection, malunion or non-union recurrence, rehabilitation, and postoperative care is important. Advantages include improved bone healing rates, reduced risk of implant failure, and enhanced functional outcomes. So I conclude by saying accordion maneuver is a bloodless stimulation of bone healing, and it is a useful tool to address non-unions and hyporegenerate with successful outcome. Successful triggering the osteogenic potential of a poor regenerate, thus avoiding more invasive and surgical procedures. Further research is still needed to find out the better techniques. Thank you.
For accordion maneuver, how many there are controversies? How many days to compress?
So,
And how many days to
so there are various principles for that. The common principle is to start compression for first 7 days, then wait for 3 to 4 days as it is, then start distraction for the next 7 days. Again wait for 3 to 4 days. 2 cycles are done for the same maneuver, and then exercise is done at the monthly interval. And then we check for signs of union. If there is no sign, then we will again follow the same principle. Thank you.
Good morning, respected chairpersons and dear colleagues. I'll be talking on assessment of the clinico-radiological outcomes of a computer-assisted 6-axis fixator for correction of foot and ankle deformities. I'm from Military Hospital, Dehradun, India. So technology is known as the great growling engine of change, in that it is now possible to simultaneously correct 3-dimensional deformities in a single sitting without taking the patient back to the operating room. The goal of correction would be correction of the deformity, restoration of limb alignment, at the same time minimizing pain, discomfort and functional limitation. So in 1991, we got the first description of external fixation for foot and ankle deformities in the Asami manual, followed by a textbook by Kirienko. Drawer Valley then described hexapod fixators in 2002, followed by a comprehensive classification of foot and ankle external fixators by Alex Cherkashin in 2018, and finally John Herzenberg and his team described the surgical techniques in 2019. We realized that we have limited studies on the results of 6-axis correction for foot and ankle deformities, and that systematic reviews are not available for comparison between this method and conventional methods of correction. So the aim of our study was to assess the results of 6-axis correction using the AOFA scores and to assess the accuracy of correction using radiological parameters using a planning software and the rate of complications associated with this procedure. Ours was a prospective study involving 15 patients from 2021 to 23, in which we included all complex foot and ankle deformities between the age 18 to 60 years, treated with osteotomies or soft tissue distraction using a hexapod device. We excluded those with an open physis, severe ankle arthritis, infected conditions, and neuromuscular disorders. Assessment was done using long leg films and segmental radiographs and a planning software using the mnemonic map the ABC. The surgical technique used was a butt frame for midfoot deformities and a vertical stack for ankle and distal tibial deformities. The osteotomy used was a Gigliso osteotomy, like so, and the tools used were the Taylor spatial frame and the ortho SUV. So here's a case of equinus. This is the planning. This is how the software simulates the correction. This is the pre-operative picture and the final outcome. Similarly, we have a girl with a distal tibial varus and short knee. We applied an ortho SUV, got the angular correction like so, followed by lengthening to give her a very precise correction like so. And this is her clinical outcome. Post-operatively, the patients were made to bear full weight for up to 6 weeks using an extension plate, followed by a custom-made brace for 6 weeks. So the mean age was about 33 years. Majority of the cases were pure equinus. The mean time to union was 3.5 months and the mean frame duration was 16 weeks. Concomitantly, we performed percutaneous TA lengthenings, followed by tibialis posterior, plantar fascia release and long flexor tenotomies. And post-Charcot reconstruction, we did beaming in 2 patients. So these were the radiological parameters that we used to assess our correction. And we can notice that all these parameters, the LDTA, tibial angle and Kite's angle, improved significantly after the intervention along with the AOFAS scores. And there were no conversions to arthrodesis. Complications included a residual varus requiring an calcaneal osteotomy, 1 case of joint stiffness and 2 cases of pin tract infections. So the traditional approach to complex foot and ankle deformities involves extensive soft tissue releases, osteotomies or arthrodesis, which have the disadvantage of large open incisions and no room for post-surgical adjustment. The Lizarov method, you have complex polyaxial hinges which require a frequent frame adjustment. 6-axis on the other hand has lesser frame adjustment and allows for post-operative manipulation of the deformity. However, it has limited space in the foot and ankle which may result in collision between the rings and the struts. So here is a comparison with similar studies, and our study has achieved a comparable EOFA scores post-operatively with a similar rate of complications. So in conclusion, perplexing foot and ankle deformities can be corrected safely and accurately upon adoption of this technological advancement, and difficulties include prolonged rehabilitation time and the potential risk for delayed or non-union. The strengths of our study included a consistent and reproducible results using these techniques. However, our study was limited by the relatively small sample size and absence of a control group. Thank you very much.
Equinus foot, you have done the osteotomy also.
No, sir. Equinus was pure soft tissue distraction.
How you take, because when you correct the equinus deformity, talus goes anterior.
Sir, so the talus is fixed to the foot ring, basically using drop wires. So the talus and calcaneus is 1 unit, and the hexapod is applied between the foot and the distal tibia. So there's you can adjust that the translation of the talus on the software itself.
Yeah, but the thing is that this is a new joint now. So usually we distract about 5 millimeters.
Yes, sir. So we did pre-distraction up to 5 millimeters, like you said. And while monitoring the patient, if there was any subluxation, we did a residual program to correct that.
Thank you.
Thank you, sir.
I'm going to talk about an ulnar osteotomy and distraction for Kienbock disease using just fixator. So, coming in introduction, it was Robert Kienbock in 1910 to traumatic malacia of donor and its consequence, which is due to an avascular necrosis of a donor, and which leads to a persistent wrist pain, decreased range of movements, abnormal corporal motion, and wrist secondary osteoarthritis. So, if you look at the cause, there is no consensus regarding the primary causative factor. So there are some risk factors which causes aggression of the disease. That is known as at-risk no-name. So these are at-risk patient is young, active male, and at-risk morphology is Vigas type 1, and at-risk vascularity is the eye pattern of the no-net blood supply. And at-risk factors are the negative ulnar variance and increased radial inclination. It was Holton in 1928 found a negative ulnar variance correlates positive with the Kienbock disease, and up to 78% correlation was found by Lewin et al. If you come to the treatment, there are multiple procedures described. So, mainly the joint leveling procedure is ulnar lengthening osteotomy and radial shortening osteotomy. So, both have almost similar results. And the disadvantage of radial shortening is a non-union, long scar, secondary surgery for implant removal, difficulty in achieving proper line. Whereas in ulnar lengthening, there is no major complications, but except some few pin tract infections. So, aim of my study was to impart Elizabeth principle of distressed osteogenesis and to address biomechanical factors by increasing the ulnar length and biological factor by increasing the local angiogenesis. So these are my study objectives to assess short-term clinical functional and radiological outcome of Kienbock disease of stage 2 to 3B. And these are my material and methods. It's a prospective cohort study conducted at Department of Orthopedics, Government Medical College, Kerala. And study conducted from August 2020 to 23, and 10 principles were studied, and IEC was obtained. So inclusion criteria for Kienbock disease stage 2 to 3B, age above 18 years, and patient willing for the study. And these are exclusion criteria: patients having secondary osteoarthritis other than this goals, and patient with history of trauma, infection, etc. patients with previous history of surgery to the arthritis. So all patients are assessed preoperatively, postoperatively, and frequent follow-up was done. And range of motion assessment, acute dash score, modified Mayo's risk scoring, and pain assessment was done. These are the operative procedures under regional nerve block. Planned corticotomy site was identified under CR Michigan. Two threaded KVS were inserted on either side of the corticotomy site, and Jex fixator was applied. And small 2 cm incision was for the corticotomy site, and minimal soft tissue dissection period was elevated. And corticotomy was done 2.5 cm proximal to the distal articular surface of the ulna. These are the posterior protocol. The active mobilization was started on day 1. Distraction started on 7th day. Rate was 0.25 12 hours. Once the planned distraction was achieved, and just was kept for 6 to 8 weeks till the union, and just removal was done on OPD basis. Arrest was applied, and follow clinical and functional assessment was done. These are the results. That is a total patients of 10. Mean age was 32.2, and male to female ratio was 3.2, and side effect was 3:2. And chief presenting complaint was all patients with progressive wrist pain. These are the clinical outcome. All patients have improved range of motion, palmar flexion from 38 to 0.2 to 62.5, dorsiflexion from 52.4 to 74.2, supination 76.6 to 80.2, and pronation 62.2 to 72.8. The functional outcome, quick dash score, modified Mayo's score, vascular all shows improved functional outcome and improved strength. So these are the pre-op and post-op of the 1 year of surgery, and these are a radiology outcome. So union fracture occurred in 2 to 3 months. The mean ulnar variance was improved from -0.2 to 2.2 to plus 0.1. No progression of the disease reduced because of the donor was found. And these are some cases where you can see the pre-op, post-op, and after removal of the just fixator. So another patient, pre-op, intra-op, and after removal of the implant. Another case, pre-op, and post-op, and implant. All the cases, the adequate ulnar lengthening was achieved, and patient has improvement in the range of motion and as well as the pain. So regarding complication, there is no major complication reported. Discharge except some discharge from pin site in 2 patients, subsided with oral antibiotics. So coming to discussion, the purpose of the study was to evaluate advantage of the distraction osteogenesis of ulnar lengthening in treatment of Kienbock disease. And idea is to impart Elizabeth principle of distractions and angiogenesis, and the consensus negative ulnar variance predispose to Kienbock disease. These are some review of literature where Amsterdam says ulnar lengthening achieved 90% of the pain relief, and there is non-union rate was 15%. Hori et al. Reported lengthening of ulnar or shortening of radius by 4 mm offloads radius, radio and donor pressure by 45%, and Elizabeth data suggests that distraction angiogenesis increased the blood supply to the limb by as much as 330%. And Altaf et al. Recently reported, according to this study, 12 patients were included. He reported 1 excellent, 10 good, and 1 fair results. So in our study, we report the following observation: 8 good and 2 fair results. All patients showed symptomatic pain reduction, significant improvement in range of motion, significant improvement in functional status. 50% showed improvement in local vascularity, no signs of disease progression, addresses all complication, conventional techniques, attained preoperative plan, ulnar length. So limitation and recommendation is the study group is small and has a short-term follow-up. No literature regarding the long-term outcome of the procedure, and say require a broader multi-centric studies needed. Thank you.
There is also ulnar negative as well as positive variants in disease. Both are found.
Both are found.
Okay. So what's your take on on those things? Number 1. Number 2, what is your longest follow-up, and what do we?
Yeah, both are more association is more of a negative ulnar variance as more prone to Kienbock disease than positive ulnar, but both are found. Those who are having positive ulnar variants, I don't know exactly what to do. But because there is one literature says both have ulnar shortening, ulnar lengthening, vertical shortening, both are recommending. So.
No, their possibility can be added with the
possibility can be
distract and then you can compress. That's a separate issue.
Yeah.
Thank you.
Dr. Jhunjhunwala, have you compared the normal wrist after the treatment or before the treatment. Normal wrist, how much is the difference between the ulna and radius in the normal wrist? Have you studied that?
Normal side of the
Yeah.
other side of the patient, other side.
Yeah, because we have to take care of that.
Yeah.
What is the other side?
We took both X-ray, both wrist AP, and measured the distance. Sometimes some patients is having ulnar variance in both sides, but pain is in the one side. Sometimes some patients having normal ulnar variance, but with other side negative ulnar variance.
And second thing, after some time, you have done the CT scan of the wrist. Previously, you have done the CT scan. So you have done in follow-up CT scan.
Follow-up CT scan is not done in these patients.
Yeah.
I assessed all the which criteria which I told. Because to CT, we need ethical committee clearance. They want for CT again doing CT is difficult.
Thank you.
These joint leveling procedures are probably done in Kielbock type 1 only actually. If it is type 3 or type more than, then you have to do a PRC or breast fusion actually.
Yeah.
Most of the rate in your cases is the article factor is already gone.
Yeah, type 2, B to 3, I done type 2 to 3B. Type 1 I didn't do.
It's indicated in type 1 only.
Also.
That's what I'm saying.
Oh. But here I got the results because in type 2B, and that's why I did the cases. Okay, thank you.
Good morning to you all. I'm going to present on tibial lengthening over intramedullary nail with Elizaro. Modern technique of limb lengthening based on the principle of destruction of osteogenesis, first described by the Elizaro. Bone transport clinically needed to gain and regain of the limb length. Elizaro was designed to regenerate and transport of the bone in case of trauma and infections. Now it becomes the method of choice for limb lengthening. Elizaro biological principle based on minimum disturbance of bone and soft tissue, control rate of rhythm destructions, stable external fixation, functional use of the limb. Now comes to the stages of Elizaro treatment techniques. Elizaro applications, period of destruction and compressions, period of immobilizations, frame dynamization, and finally the period of immobilization with the brace. Dynamization is done when satisfactory regeneration, recalcification, recanalization, and formation of cortices are seen. Dynamization done by the loosening of nuts at the site of connecting rods. Now comes to the lengthening over the nail. Advantages are reduce the total bone modeling and remodeling times. It's required simultaneously placement of intramedullary nail and Elizaro rings, and corticotomy done at the same time. Followed by destruction of osteogenesis, and after achieving the adequate length and consolidation of bone, Elizaro ring removed, while intramedullary nail left as such for further consolidation and strengthening of the bone, which is removed later on. Prerequisites are skeletally mature individual. No, there should be no any active intramedullary infections, stable hip and knee joint, and no severe angular rotational deformities. Now comes to the surgical steps. Thorough debridement of infected tissue and bone to be done. Methylene blue injected, which confirms the dead tissue and necrosed bone, which should be removed, and fracture site is present. Intramedullary nail done, followed by Elizaro ring applied, and finally corticotomy done, distal or proximal to the ring, depending upon the direction of the bone to be transported. Contraindications are infections, non-patent medullary canal, segmental loss of extremities, skeletally immature deformities around the knee and ankles, and pitfalls are the prolonged time of treatments, expected regional surgery, patent compliance, difficulty in proximal and distal short segments, resident malalignment, quality of regenerate are the multifactorial dependent on the stability, destruction, and health status, non-union at the docking site, fracture at the docking sites, and pin track infections, and regenerate infections. Now this is the case of the non-union. External fixated are applied somewhere else, and we had done the ESR and CRP are within the normal range, so we had removed the dead piece of bone. methylene blue injected, which further confirms there's no any further infections. We had removed, then followed by intramural nailing was done. Then external fixator was applied and corticotomy done at the same time. Active ankle movement started from the next days, and toe touch will started. So bone transport is done from the distal to the proximal. So this is another case with the infected non-union. So we had methylene blue injected. We had fracture sideways freshen and removed all the dead piece of bone. Then we had intramural nailing was done and followed by laser ring applied on proximal and distal, and corticotomy done distal to the distal rings, and bone transport is done from the proximal to distal. This is another case of infected non. We had removed the dead piece of bone, intramural nailing done, and laser ring applied. Corticotomy done proximal to the proximal ring and bone transported from proximal to distal. So we had, in this case, I had complete transport of bone was done, and we had removed the dead piece of bone. And so we had after the complete transport of the bone, we had removed the rings and intramural nail left in situ for further consolidation and strengthening of the bone. Thank you. Sir.
That you are doing an infected case
So we had,
and you put an intramedullary nail.
sir, first we had removed the dead piece of bone. We left the patient as such for the 1 or 2 weeks.
No, the wound was open for 1 or 2 weeks.
No, sir.
Then what? You never showed any flap and all.
Sir, we had closed the soft tissue and bone. We had closed the soft tissue. After we had do the ESR and CRP. When there is ESR CRP within the normal is, then we do the cases.
See, basic rule is that if it was infected, even though everything you are debrided and everything,
Yes.
but you can't be 100% sure that the infection will not reactivate. I will not dare to put a nail.
So
I will never dare to put a nail in this
we have
case.
done the
So
cases.
probably it gives a wrong message to youngsters that okay, this is a very heroic surgery you have done, but the message is not conveyed in a proper way. You understand? So I would not do. I don't. Question?
May I ask you, so how long time you have follow-up of your cases?
Sir, for the last 1 year, I have. The third case which I had completed the complete transport, I had last 1 year's follow-up, sir.
And one more question. How much often and how much cases you have recurrence of infection? You saw that.
I had done the 3 cases, sir.
Recurrence of infection after your surgery.
And I had not seen, in 3 cases I had not have any.
And that's okay. I hope that finally will be good result, but I'm not sure on that because in infected fracture, in infected non-union, you put inside at the same time nailing and frame, and it's very dangerous and very complicated.
As it is a gold medal session company, so I have no right to comment actually. That's not take time anyway. So my question is, you are putting the nail.
Yes.
You are doing the corticotomy. So you are externally also, internally damaging the vessels also. So don't you think that will hamper your regenerate? Because you are putting it vascular or inside also. In corticotomy we try to preserve. So when you are putting the same shit in the nails, so are you not damaging it?
Sir, after removing the dead piece of bone, we had wait for the 1 to 2 weeks, sir. When we are seeing there is
No, sir's question is different.
Yes.
And I will, I think, answer. You won't be able to answer. See, I have done many of these cases. What happens that in a bone regeneration, it has been found in studies and it has been proved by Dr. Pele also, That endosteal callus has a little role in regeneration, and is mainly the periosteum. So for if lengthening of a nail, the regenerate comes late. Regenerate is slow, but it comes. It is proved. But if it is infection, it does not come. So that's why my main question mark was, but why did you put a nail inside? You could have done without a nail. You could have done it without a nail.
One comment, never present any case if you don't have enough follow-up at least 1 year, okay? Huh? And if you cannot show the clinical pictures at least also for 1 year, okay? Huh? No, only one case you have to show the result of 1 year, so that should not be. Okay. Thank you.
Thank you.
I'll be speaking on my research work on management of complex non-unions of long bone using limb reconstruction system. I'm Dr. Ankit Mittal, working as an additional professor in UPMS FI Itawa. As we know that complex non-union is described with the following established criteria, which should be present for at least 6 months: infection at the site of non-union, a bone defect of more than 4 centimeters, and attempt to delivery which has failed. Attempt for union which has failed. Traditionally, complex non-unions have been managed by a leather ring fixator, but it's a cumbersome and heavy device, and now LRS has been commonly used, which is less bulky and a uniplanar system. It also allows dynamization at the site of the fracture. So this study was conducted to assess the union rate, infection control, lengthening, and the complications associated with the use of LRS. Material methods. The study was conducted between March 2021 to April 2022, and we had 25 cases in total, out of which 11 were femur and 14 were tibia. All our cases were of lower limb only. And the patients with congenital disorders and pathological fractures were excluded from the study. So finally, we had a follow-up 25 cases which were evaluated. Out of them, most were males. There were only 4 females, and the rest 21 were males. 10 cases presented with an already infected implant. The average shortening preoperatively was 6.5 centimeters. The details of the patients. The details of the non-union. Mean duration of non-union presenting before the patient presented to us was 8.2 months. The photographs, the radiological photograph of a patient in which there was a fracture of short femur and we applied LRS and achieved union. The follow-up X-rays at 18 months. A follow-up of another patient in which there was non-union of tibia in which LRS was applied. The follow-up at 1 year and the clinical photographs. Another patient with infected implant in which the KYs were removed and LRS was applied, and bone grafting from fibula was done, and union was achieved at 18 months. Infected patients were initially managed with implant removal, radical debridement, and fixation with LRS. In 5 cases, we used PMMA beads also, in which the antibiotic like gentamicin or vancomycin was used. There were no clinical signs of infection for 6 and 8 weeks, then the cement beads were removed. Corticotomy and bone transport was done in 14 cases out of 25. Bifocal corticotomy was not done in any case, and the compression was done at the fracture site at 0.25 millimeter per day. LRS was maintained till radiological signs of union were achieved, and we waited for 4 weeks before the removal of LRS. The post-operative protocol, ambulation and partial weight bearing was started immediately after 2 to 3 days after surgery. At each follow-up, the problems of inside infections and pin loosening were assessed, X-rays were got, and the average duration of treatment that we found was less for femur as compared to tibia. The statistical tests used, the final results that we obtained. So we had a final outcome of 25 patients, out of which complete union was achieved in 21 cases and eradication of infection was achieved in 22 cases. 14 cases underwent limb lengthening. The average lengthening that we achieved was 5.23 centimeters. The range was from 3 to 8 centimeters, and the mean residual limb length discrepancy that was left after treatment was 1.48 centimeters. A bar diagram showing the limb length shortening pre-operatively and post-operatively. So post-operatively is the orange bar, the final follow-up at 18 months, and we had 15 patients with both the limbs equal. We had 6 patients with less than 1 centimeter limb length discrepancy, and we had 4 patients with 1 to 3 centimeters of limb length discrepancy, and we didn't have any patient with more than 3 centimeters of limb length discrepancy at the final follow-up. Finally, there was no low limb length discrepancy in 15 cases. In 6 cases, it was between 0.1 to 1 centimeters, and in 4 cases, it was between 1.1 to 2 centimeters. There was no significant difference in the post-operative and pre-operative joint movements, and the results were classified. Results were graded using the Asami scoring system as excellent, good, fair, and poor. The complications were classified according to Bailey's classification. The problems represented difficulties that required no operative treatment, obstacles represented difficulties that required an operative intervention, and all intraoperatively injuries, difficulties during limb lengthening that were not resolved before the end of the treatment were considered as true complications. The most common problem that we faced was spin tract infection, which was seen in 10 out of 25 patients. The second common problem, the most common obstacle that we saw was spin loosening, which was seen in 4 patients, and joint stiffness was also most common true complication. Other complications that we noted were angulation, premature union of poti-poti site in 2 patients, equinus in 5 patients, persistent discharge in 3 patients, and refracture in 1 patient. Finally, there was no angulation in 21 patients. In 2 patients, it was less than 5 degrees, and in 2 patients, it was between 5 to 10 degrees. Elizarov scoring system was used for the assessment of functional results, and they were categorized into 2, bone results and functional results. Bone results and functional results were further categorized into excellent, good, fair, and poor. And they were mainly based on the union at the fracture site, the presence or absence of infection at the final follow-up, and the residual deformity and limb length discrepancy. The functional results were based on the presence of the stiffness and other complications. Showing the table showing the final functional results, we had excellent bony results in 15 patients and excellent functional results in 11 patients. That means bone results were better than the functional results. In discussion, as we all know that Elizarov has been traditionally used, but LRS is a more simpler device, but it's uniplanar, and LRS is more stable because of its robust complication. In our study, we had a union rate of 84%, out of them 28 were by primary union and 56 were by bone transports. Other studies have also been conducted which have shown more or less similar results. The complications we managed, and there was premature union of poti-poti site in 1 patient, and there was final residual 2 centimeters of limb shortening. The limitations, there was lack of a control group in our studies. We had more of male patients than female, and we included patients. We had patients between 18 to 65 years of age group in our study. So finally, to conclude, the complex non-union have been satisfactorily managed with LRS application, and it's a good alternative to Elizarov fixation. Thank you.
To the literature, see what is the problem with LRS biomechanically as you compare it with Elizarov. Can you tell me?
Yes, the main problem is that it's a uniplanar fixator, and that's why complex deformities are difficult to correct.
What about the stability?
It doesn't offer stability in all the planes, as we can have stability in one plane but not in the other plane.
And what about the stiffness?
It's a more rigid form of fixator.
So rigid form is a good thing, or it's a, as you compare with Elizarov, what I want to know whether you have gone to the literature and checked your, the lengthening index, and whether there was a difference in the regenerate in LRS and Elizarov. Because Elizarov has a flexibility as a micro motion. This is a very stiff type of fixator. So did you find any difference in the rate of union or lengthening index?
I have compared 4 studies. I have compared in which 2 were of Elizarov and 2 were of LRS. But the results I got were that they have shown, as per the Elizarov scoring system, better excellent results with LRS device. I can show the table also in the presentation house.
There are one study only. My question is, have you, there were 8 centimeter also gap in one case, 2.3 to 8
It's a maximum gap, maximum.
Why have you not gone for trifocal osteotomy? Because that will give the much less time. So why have you not come for that? Number 1. And number 2, you are lengthening, but still why 2 centimeter shortened in few cases? Because you could have Jolene avoided it. If you can explain.
So
I got the question. Question number one: why have you not chosen? You have told that you have not gone for except trifocal, never trifocal. Why? Any reason for that?
So there was
Okay.
one patient with this much of shortening, and we tried to manage.
No, more than HCT is quite big. So that will. Anyway, and why 2 centimeters shortening? You can see and check. So why have 2 centimeters shortening? Even when you are lengthening it.
So we tried to manage 2 centimeters of shortening by giving the patient a shoelace, and we tried to. Thanks. The patient wanted a shorter course of treatment. That's why we opted for it. Thanks.
Thank you, sir. Anybody else?
Come to the literature, see what is the problem with LRS biomechanically as you compare it with Elizarov. Can you tell me?
Yes. The main problem is that it's a uniplanar fixator, and that's why complex deformities
And what
are
else?
difficult to correct.
What about the stability?
It doesn't offer stability in all the planes, as we can have stability in one plane but not in the other plane.
And what about the stiffness?
It's a more rigid form of fixator.
So rigid form is a good thing, or it's a, as you compare with Elizarov, what I want to know whether you have gone to the literature and checked your the lengthening index, and whether there was a difference in the regenerate in LRS and Elizarov. Because Elizarov has a flexibility as a micromotion. This is a very stiff type of fixator. So did you find any difference in the rate of union or lengthening index?
I have compared 4 studies. I have compared in which 2 were of Elizarov and 2 were of LRS. But the results I got were that they have shown, as per the Elizarov scoring system, better excellent results with LRS device. I can show the table also in the presentation accounts.
There are one study only. My question is, have you? There are 8 centimeter also gap in one case, 2.3 to 8
It's a
centimeter.
maximum gap, maximum.
Why have you not gone for trifocal osteotomy? Because that will give the much less time. So why have you not come for that? Number one. And number two, you are lengthening, but still why 2 centimeter shortened in few cases? Because you could have Jolene avoided it. If you can explain.
So
I got the question. Question number one: why have you not chosen? You have told that you have not gone for except trifocal, never trifocal. Why? Any reason for that?
So there was one patient with this much of shortening, and we tried to manage.
No, more than HCT is quite big. So that will. Anyway, and why 2 centimeters shortening? You can see and check. So why have 2 centimeters shortening? Even when you are lengthening it.
So we tried to manage 2 centimeters of shortening by giving the patient a shoelace, and we tried to. Thanks. The patient wanted a shorter course of treatment. That's why we opted for it. Thanks.
Thank you, sir. Anybody else?
At the outset, I thank Team Asamicon for this opportunity. I'm Dr. James Curris, and my question today is: does timing of debridement, fixation, and corticotomy matter in different grades of severity in infected tibial bone gaps? We present our work on the strategies and outcomes in bone transport. What are the problems that we face in these conditions? Limb length discrepancy, problems with bone and soft tissue loss, problems associated with infection, deformities in their various planes, and adjacent joint contractures. We studied 87 cases retrospectively over 22 years. And the burning questions in our head were: do all patients need debridement? Is there any benefit in delaying fixator application in some cases? Any advantage of delaying corticotomy in some cases? And why not just do it all at once? So, we present our algorithm based on the types of treatment strategies
based on the timing of debridement, Ilizarov application, and corticotomy. Our type 1 cases consisted of patients with minimal gap and no active infection when they presented to us. Most of them were previously infected, so we applied the Ilizarov and did corticotomy in the same stage. Here's a 29-year-old gentleman with multiple previous surgeries presented to us with limb discrepancy. We applied the fixator and did the corticotomy in the same stage, leading to excellent outcomes in the end. Our type 2 treatment strategy consisted of patients with larger bone gaps and active infection signs. These were debrided with local antibiotic delivery in the first stage, followed by Ilizarov and corticotomy together after 6 weeks. Vancomycin was used in its various forms for local antibiotic delivery. There was a 65-year-old gentleman who presented to us with non-union. He was debrided with resection of the infected segment, followed by Ilizarov and corticotomy after 6 weeks. In the end, leading to excellent results. A type 3 treatment strategy consisted of larger gaps with extensive canal involvement and severe infection and osteoporosis. Here, we debrided with Ilizarov, in the first stage with local antibiotics delivery. We applied the fixator after 6 weeks in the second stage and did a corticotomy 6 weeks after that, once the general condition of the patient improved and the negative nitrogen balance in the body had improved. Here's a 39-year-old gentleman who presented to us. We debrided it in the first stage, followed by fixator application in the second stage and corticotomy in the third stage. Most of these patients were corticotomized later, and we observed that their regenerate quality was very good after the negative nitrogen balance in the body had settled. Our type 4 treatment strategy consisted of patients with extensively large bone gaps and infection. Here, we applied the fixator and did the debridement together, followed by corticotomy 6 weeks later. Here's a 29-year-old gentleman who presented to us this way. We applied the fixator, did multiple debridements, vac dressings. We then did the corticotomy after the soft tissues condition had settled and overall infectious markers had reduced, and the general condition of the patient had improved by that time, leading to excellent outcomes in the end. This is the age distribution for our study. Most of our patients were males, with right being the most common side. Distal tibial non-unions were more common in our study. We did corticotomy by multiple drill holes and even the Gately saw method. The mean shortening was 7.1 centimeters at presentation. Depending on the type of treatment strategy, the initial shortening was found to be increasing. Proximal level lengthenings were most common. We also had 3 cases of trifocal osteosynthesis. The mean amount lengthened was 6.4 centimeters. The mean fixator duration was 435 days, and the fixator duration also increased according to the type of treatment strategy that we applied. The mean external fixation index was 68 days. The residual shortening in our study, the mean was 0.8 centimeters. Bone grafting had to be done in 14.9% of our cases. However, there was no difference in the fixator duration between those who were grafted versus those who were not. 85 out of 87 cases united in the end. There was no residual infection in any of the patients, including in patients who presented to us with such a bad infection.
The average deformities in our study were less than 7 degrees. There were only 2 patients with poor Asami bone scores. Type 2 and type 3, 1 patient each fell in the poor bone scores. 12 cases needed to be applied with the femur frame. The hinges were applied for knee movement. 28 cases needed foot frame for stability.
Your time, sir.
Masculine technique we found as unreliable in the tibia bone transport. I'll just conclude. This is the conclusion slide that I would like to present. And
Slides not playing.
okay, sorry.
You can just speak. What is your conclusion?
We have devised a strategy based on the 4 types, and our conclusion is that the patients with larger gap who need stability, they need the fixator at the presentation, and in the bones where you find that they are not very osteoporotic, the fixator should be applied at the time of presentation. And if there is extensive canal,
Means Lisrov fixator.
yeah, at the time of presentation.
And if there is a skin loss and a lot of skin problems,
Yes,
would
sir.
you first like to put a normal fixator till the skin settles down and then you convert, or primarily you want to put an Lisrov?
Primarily,
Won't
you
it
put
hamper in
an
your plastic surgery?
Pardon, sir?
Won't it hamper in the plastic surgery work if you want to do a flap?
In the case that we showed,
Yeah, just generalize, I'm asking you.
right, sir. What if the patient needs a plastic surgery?
Yeah.
So in our study, we had very few cases who actually needed the plastic surgery, because we did find that while doing the transport, there was also the soft tissue coverage that we attained. So applying the fixator in larger gaps at the initial presentation is always beneficial, but the quality of the bone, the extent of the infection should be taken into account before making that decision. If the bones are very osteoporotic, if extensive canal involvement is seen with infection, then probably we should delay the fixator application, debride it, allow the patient to walk on with a brace, improve the osteoporotic condition of the bone, and then apply the fixator.
Okay, we'll move on to.
Good morning, everybody. Distraction over 5 cm is associated with ischemic regenerate formation or hypoplastic regenerate formation. Decrease the callus diameter ratio leading to the fracture of the regenerate. Deformity within the regenerate after fixator removal. Increased age increases the chances of poor regenerate formation. Poor regenerate predisposes chances of bone grafting of the regenerate to enhance healing. Callus subsidence chances increases with poor regenerate.
1 minute, you are reading everything like a poem. So,
7 minutes is the time. So I have to finish it before 7 minutes. Poor regenerate quality is associated with bone healing, increased lengthy bone healing index, thus increasing the complication rate. Average bone healing index reported for bifocal destruction osteogenesis is around 52 to 69 days for a destruction gap of 7 cm. Burgeois et al. Proposed multi-level osteotomy for larger defects to reduce the length of the stay in fixator. Tetrafocal and pentafocal osteotomies are effective in reducing the bone healing index for bone defects larger than 6 cm. But none of the studies have compared the region rate of multi-level osteotomies. Fractures are reported after fixator removal. Many alternatives have been tried to reduce external fixation and associated complications like hybrid fixation, exchange nailing, exchange plating, prophylactic internal fixation for poor regenerate. Stimulation of poor regenerate with stem cell injections, PRP injection, ultrasound therapy, and electrical stimulation. So, distraction phase is crucial for sowing seeds of future regenerate formation and its outcome. While many other factors play vital roles, we will concentrate on the role of distraction. The standard distraction rate 1 mm per day in 4 increments, but regeneration formation is not uniform in the same age group. Distraction speeds of 0.5 and 1.5 mm favorable, while slower and higher speeds result in poor regenerate formation irrespective of the size of the distraction gap. The introduction of motorized distraction devices brought the idea of continuous distraction rather than an incremental distraction, while the former has not shown any advantage over the later in reducing bone healing index or external fixation index. Varying rates of distraction have not shown effectiveness in developing better regenerate, but varying speeds have shown effectiveness in improving regeneration quality, but it is only a computational study. So the aim of our study is to study the distraction holiday and regenerate healing index in bifocal distraction for defects larger than 6 centimeters in tibia. Study is retrospective. Data collected during 2018 to 2022 at Sunshine Bone and Joint Institute, Hyderabad. Inclusion criteria: patient requiring distraction osteogenesis for more than 6 centimeters. So all patients were a distraction protocol. All patients were advised to distract 1 mm per day for 10 days in 4 increments, followed by a 4-day distraction holiday. This sequence is repeated till the desired length is achieved. Radiographs were done every 15 days in the first month of distraction and monthly in the subsequent month. Monthly X-rays were done during the consolidation period. Hounsfield units were measured in the consolidation period at 5 points in the MedSynapse PAC software. Criteria for frame removal: appearance of 3 out of 4 cortices and API and lateral radiographs, a difference of less than 20% Hounsfield units compared to the Hounsfield units of the nearest cortical bone as measured on the PAC software. The distraction gap is bony hard for palpation and non-tender compared with the adjacent healthy bone. Patients were taken for mechanical stress testing. When any up to above criteria were met, the fixator is removed, regenerate is resistant to rotational valgus varus stress on fluoroscopy. After fixator, above knee long cast was applied for 3 weeks for the subsidence of swelling and pin tract infection. Post 3 weeks, PTP brace is applied and full weight bearing is started for 3 months in the brace. So results: a total of 9 patients were included in this study who underwent distraction holiday technique with an average age of 29 years, age 18 to 67 years, 8 males and 1 female patient. Average distraction gap is around 8 cm. All patients underwent bifocal distraction. This is the patient characteristics of all the patients. 7 had fracture-related infection. 1 is congenital limb-line discrepancy. The other one is limb-line discrepancy secondary to the tumor. So callus was usual on X-rays within 30 days in all patients. 7 patients had proximal corticectomy. 1 patient had one distal corticectomy and 1 patient had mid-shaft corticectomy. Mean distraction gap is 8.05 centimeter. Mean bone healing index is 37.8 to 82 days per centimeter. Mean regenerate healing index is 32.99 days per centimeter. 7 patients had type 9 callus at the time of frame removal. 1 had type 7. All patients had cylindrical shape of the callus. 1 patient had a docking site delayed unit and 2 patients want the fixators to be retained for more periods due to past bad experience. And 1 patient did not come in time for fixator removal of stress testing. None of the patients had pain at the regenerate site while walking in the PTP brace and during the
you have written none of the patient had pain at regeneration site while walking in the PTP brace and during the distraction period. Means if the fixator was on.
That means while distraction phase they did not have pain, and then after the fixator removal also in the PTP brace.
Written because this gives a message that
the most common complication of intract infection which subsided with oral antibiotics. Docking site translation corrected with hinges. 1 patient had skin invagination at the docking site which was corrected under local anesthesia. All preoperative equipment is corrected with additional foot frame. So we have also compared our results with regenerate consultation time in comparison to distraction time. Regenerate in our study concentrated 13% faster than the expected consultation time. So we have measured Hounsfield units serially. When the Hounsfield units of the cortical bone and regenerate were at a difference of 20%, fixator was removed. So conclusion: our outcomes are comparable to tetra and pentafocal distraction osteogenesis, well within the limits of upper limit threshold set by last count less than 45 days per centimeter. Distraction already improves healing and aids in forming better callus type shape, thus reducing healing time. Bone mineral density of the regenerate is more important predictor for fixator removal than the 3 cortical appearance on the X-ray. In our series, we had only Two cortical appearances, our findings are consistent with Saran et al. They had only 1.5 cuts. Distraction already helps in recovery of the soft tissues and avoids distraction. These are the exercises.
What was your age group of the patients?
18 to 65.
18 to 60, but did you compare with this? You will do this same process in children?
Children, I don't get much children.
But will this holiday will be applicable to children also?
Yes, we can do this because I had one metacarpal shortening.
But during that children, the consolidation happened very fast. The corticotomy might get consolidated.
But we don't have experience with that, but we have to try it. We don't know. We have done this only in the adult age group.
Good morning, seniors and respected colleagues. And my study, I'm Dr. Vel Murugesan from Coimbatore. My study is on analysis of management of open tibial fractures with primary bone loss treated with the limb reconstruction system. Bone transport with ring fixator proposed by Elizaro is an effective means to fill bone defects. However, limb reconstruction system is it also follows the same principle, and it is uniplanar and more simpler to apply and has a simpler learning curve. But the major concerns are the potential deviation of the transport fragment and subsequent angulation, which can result in mal docking and cause docking site healing problems. And if you are not careful aligning the proximal and the distal fragments while application of the frame, it can result in mal alignment and deformity subsequently. To prevent this, various authors have reported techniques such as transport over nail or a transport over plate. Right? And we have devised a simpler technique of temporary spacer rod and plate technique, which to reduce the dockings, to enhance the docking site contact and reduce mal alignment. And in our initial retrospective analysis of 35 patients in whom we have done this technique, we found that we could achieve circumferential docking in 88% and no deformity in 85% of the cases. However, to know the effectiveness of this technique, we wanted to validate it by comparing it with the control group. So the aim of this study was to analyze whether the spacer rod and plate technique improved docking site contact and whether it reduced the mal alignment and then reduced the need for secondary surgery for docking site union and shortened external fixator time versus a control group. This is a retrospective study done at Ganga Medical Center in Coimbatore. We, with the open tibial fractures with primary bone loss treated with the limb reconstruction system. Our study duration was 2 years. We included patients above 18 years with the open tibial fractures with primary bone loss. We excluded patients with bone loss due to other causes, whom we have done trifocal transport or other more ring fixator for bone transport, and those who are lost to follow. We collected the demographic and injury particulars and treatment details from the hospital record system and PACS. So we measured the length of the bone gap in the X-ray with the standard magnification, and then we assessed the docking site contact by dividing the width of the bone into 3 segments. And based on the number of segments that were in contact, we divided them into good or circumferential contact when 2 or more segments were in contact, and poor contact when less than 2 segments were in contact between the 2 bones. And the final follow-up, we also measured the joint orientation angle of proximal and distal tibia. If it was more or less than 5 degrees, we considered them to have a deformity. And that final follow-up, we also assessed the Asami bone and functional score. So we had a total of 1,117 patients of open tibia fracture during the study period, of which 94 patients had a bone loss of more than 4 cm. In which 77 patients we did bone transport by LRS, and 55 patients had a full follow-up, in which 1 patient had to undergo secondary amputation. And out of the 54 patients, we had done 22 patients with the LRS using the spacer rod and plate technique, and 32 patients without it. So this technique, after the debridement and bone gap is established, we use these cylindrical rods which are 8 mm in diameter, and we carefully insert them into the bone gap. And we also use a plate to hold the bone ends, either with 2 screws or with a plate. And we make sure that the rod is not inserted more than 2 centimeters so that it can be removed easily. And in case of short metaphyseal fragment, we try to place them in the more central location with by creating a trough or using pins to help it stay in the central position. Because any eccentric position will result in malalignment. So here we could achieve a circumferential contact after the end of the transport and went on to unite without any malalignment. So when we assess our results, we find that age and bone loss location and gap of bone length loss, which was all comparable to both the group. However, the Ganga Hospital injury severity score was significantly higher in non-spacer rod group. And we also find that the spacer rod group, we could achieve 90% of the patients in spacer rod group, we could achieve good contact. And when we did a subgroup analysis of patients with poor contact, we find that mal docking to be the major cause of poor contact and the bone loss. Similarly, in the spacer rod group, there was a significant reduction in need for secondary surgery, and we had done 33 patients in secondary surgery in 33 patients, and these are the list of the surgeries. And we could also find there was a significant reduction in the deformity with the use of this technique. However, there was no difference in external fixator time or the maturation index. Similarly, there was no difference in Asami functional or bone score at the end of the treatment. This is a case example where we have treated a bilateral open tibia fracture with a spacer rod and a plate, and then done a primary LRS on both sides. At the end of the transport, he had a circumferential docking of both the legs, and he went on to unite without any need for secondary procedure. Our complication rates were similar in both the groups. We had one non-union and in tibia. However, that patient had cross-union in the fibula, so no secondary, and he was walking comfortably, so no secondary procedure was done for it. And he had one amputation. And when we compare our overall malalignment rate with that of the literature, we find it similar, and it is 33%. We could reduce this malalignment rate by nearly 50% whenever we use a spacer rod technique. And it has been systemic review by Peter Guinades. He has reported that poor bone contact and mechanical stability is one of the factors in need for secondary procedure. Our study, 90% of the patients with poor contact needed secondary procedure. So in conclusion, spacer rod and plate technique definitely improved the docking site contact, reduced the need for secondary surgery for docking site union, and reduced the malalignment. However, no difference in external fixator time and outcome in both the groups. Thank you.
My question is that when do you remove this spacer rod?
At the end of application of the LRS, we remove the
Immediately that time.
slate is also removed.
It's just for alignment.
Just for the alignment.
Means he will remove everything after surgery.
Thank you.
Thank you, sir. Anyone else has any questions?
Good morning, respected chairpersons and dear friends. My paper is functional and radiological outcome of proximal tibia fractures managed with Elizaro technique with or without minimal internal fixation. As we all know, proximal tibia fractures are one of the commonest fractures seen worldwide, and often they are associated with extensive soft tissue injuries. Frequent post-operative complications like wound dehiscence, infection, and non-union. For better outcome, we need anatomical reduction and stable fixation in these cases. Complications of internal fixation in these cases are high, to the score of almost 23 to 41%. There is high incidence of hardware prominence and even non-union. Advantages of Elizaro in these cases that the fixator is a stable, it's a modular fixator, avoids extensive soft tissue dissection, doesn't require any major surgery for implant removal, and it permits early weight bearing. Inclusion criteria in our study was proximal 1/3 tibia fractures. We included intra-articular as well as extra-articular fractures, and we included 2 patients who had open injuries and bad soft tissue conditions. Exclusion criteria were vascular injuries, associated same-side femur fractures, and patients who were not motivated for Elizaro surgery. Our study duration was from June 2019 to June 2023. It was a prospective study. We had 35 patients in our study, and mean age was around 41 years. Coming to the surgical procedure, we had done everything under all the patients operated under spinal anesthesia. Most of the patients were operated on fracture table, which helps to reduce the fracture. It avoids need of one assistant. We get 360-degree access around the limb for wire and pin insertion, and it facilitates C-arm movement. So we can see how traction helps easily to reduce the fracture without need of any assistance, and then we can manipulate with the reduction forceps and reduce the fracture very well. Coming to the surgical procedure of Elizaro frame application, once the articular reduction is assessed, depressed articular fragments sometimes may need minimal exposures to elevate them. Cannulated screws were used in a few cases to aid articular reduction and interfragmentary compression. So for that, we locate the depressed articular fragment and pass a guide pin, then make a small cortical window and insert a punch to elevate to aid in articular reduction. Sometimes when articular reduction is achieved, we use cannulated cancellous screws and then Elizaro frame application. We had used 3-ring frame application in most of the cases. In type 6 Chatler cases, when there is an extensive diaphyseal involvement, then we may need to add a 4th ring. First ring is subarticular at the knee joint. We use minimum 3 wires through the ring, usually olive wires to get interfragmentary compression, and one of the wires transfixes proximal tibiofibular joint, and 1 or 2 drop wires or half wires. Second ring is 2 wires with adequate spread between the 2 wires or 1 wire and a stance pin, and third ring is subarticular at the ankle joint, 2 wires with adequate spread or 1 wire and a stance pin, and one of the wires in the ankle ring transfixes distal tibiofibular joint. We need to span knee joint in a few cases. The indications are if you consider soft tissue contusions around the knee joint, articular surfaces are multifragmentary and there is severe combination, and if we expect a collateral ligament damage, then we span the knee joint. If distal femur ring is used, it is removed at 3 to 4 weeks. Ring removal is done after radiological union, usually at 4 to 5 months. We dynamize the frame and then after 2 weeks we remove the frame. It is a OPD procedure with or without sedation. Aggressive range of motion and strengthening exercises were encouraged after implant removal. A walking cast was given for 1 month and patients were asked to use hinge brace for further 3 months after the implant removal. Our assessment was according to Rasmussen's clinical criteria, which uses subjective complaints of pain and clinical signs of range of motion, extension lag and stability. So most of our patients had excellent results. 22 out of 35 patients had excellent results and 1 patient had a poor result. Radiological criteria were according to articular depression, condylar widening and angulation. 29 patients had excellent result and no poor result. So all patients achieved radiological union at 20 weeks. All patients started full weight bearing at 12 weeks. Mean range of motion at the knee joint was 128 degrees. 10 patients had pin tract infections which were managed with dressing and oral antibiotics. None of the patients required repeat surgical intervention. Only 1 patient had major complication in the form of chronic septic arthritis of the knee joint with pain and restricted ROM, but he is not willing for further surgical procedure, so we had not operated him yet. Coming to the examples, first case is a 19-year-old male road traffic accident, extra-articular tibia fracture with bad soft tissues and contamination. We did debridement and Elizaro ring fixation in the primary setting. This is 2 months and 4 months follow-up. We removed the ring, and this is 2-year follow-up when we had when the patient had good range of motion and is doing all his routine activities with good alignment. Second case is 35-year-old male with again road traffic accident, had hemorrhagic blisters, type 6 Jhunjhunwala tibia fracture. In this case, we had to span the knee joint because of severe combination. These are the X-rays at 3 weeks. Then the femoral ring was removed at 2 months and 4 months, showing good union. This was the video just at before the ring removal. Third case of 25-year-old male road traffic accident with widely displaced condylar fractures, bad skin and blisters. Here, olive wires from the Elizaro apparatus comes handy for articular reduction and metaphyseal reduction. So strategic placement of olive aids in reduction of the fragments and even articular reduction. So this was the post-op and 3 months post-op X-ray. This was at 1 year. We had very good alignment, slight virus, but it was within the range of acceptable limits of 3 degrees. So fourth case is type 6 Jhunjhunwala fracture, road traffic accident with very severe combination and bad soft tissues. We had a full thickness ischar on the anteromedial aspect of the knee joint. We did primary Elizaro fixation. Plastic procedure was not done. Once the ischar was out, the wound healed by secondary healing. And at 1 year, patient had good union This video was just before the ring removal when we test clinically removing the rods. So our conclusion is iliaceral ring fixation is an excellent method of fixation in proximal tibia fractures, intra-articular as well as extra-articular. It gives stable fixations, it enables early mobilization and bed bearing, and has very good union rate. It prevents damage to soft tissues which are already compromised in such fractures, and it obviates need for second major surgery as implant removal is a OPD basis procedure. Thank you so much.
My question to you, see, in proximal tibia, high velocity trauma, lot of blister formations. When do you operate? Suppose patient comes to you on day 1 or day 2 with blister formation. When are you going to operate?
Sir, we waited for 4 to 7 days till the swelling disappeared and the limb was supple. We did not wait for reepithelialization of the blisters, but once the swelling was supple at around 4 to 7 days, we had operated the patients. Because reepithelialization takes almost 2 weeks to 3 weeks in some cases, so we did not wait for that much. We operated between 4 to 7 days.
See, I have a very large series of more than 50 cases. You can operate immediately. Why? Because these wires, they decompress the compartment. So blisters should not be a kind of this thing that I have to wait for 3, 4, 5, 7 days and then I operate. You decompress the compartment, and if you see that when you put wires, you see the next day, normalcy starts coming. Swelling reduces and it starts getting normal.
So the practical problem at our setup was it's a government setup and the approval for surgery takes around 2 days, so we had to
No, that is not the thing, but
I accept the point that we can operate it on the first day. Yes.
And operate on the first day, and how many cases you have done till now?
So this series included 35 cases.
35 cases.
And I have a question too. And my question is, what are you doing with the painful after removal of device in a knee joint?
After removal of the fixator?
Yeah. What you do with painful after removal of device in a knee joint? Because we saw a lot of cases with very biggest deformity and disorders in the knee joint, and of course it's very painful for the patient. What do you do for that?
So we do physical therapy with local ultrasound, and if needed we add opioid analgesics like tramadol.
And it's help?
Yes.
Thank you, sir. I'd like to call unions of long bones pose a challenge to the treating surgeon, and those of an upper limb are in turn an artist's task. In spite of recent advances in orthopedics, we still encounter cases, recalcitrant cases with failed internal fixation, and the one-stop solution to this is the iliaceral external fixation, and hence this study was taken up. Good morning everyone, I am Dr. Godasri, consultant orthopedic surgeon from Hyderabad, and my paper is going to analyze the radiological and functional outcome of infected non-unions of upper limb managed with the iliaceral external fixation. So these are the aims of my study, as already said. There were 10 patients who were operated between 2021 to 2023. 7 of them had infected non-union in the humerus and 3 of them had it in the forearm. There were 7 males in the series and 3 females in the series. The mean age was 41.3 years. The average number of surgeries which each patient underwent was 2.8, ranging between 1 to 5, and all of the cases were assessed pre-operatively, both clinically and radiologically, and planned well. There were 2 patients with infected non-union in proximal third of humerus, 4 in the middle third of humerus, and 1 in the distal third of the humerus. Out of the forearm, 2 had both bone infected non-unions in the middle third and 1 in the distal third. There were 4 cases which required bone transport, 3 in the humerus and 1 in the forearm. And for the cases which required bone transport, I proceeded at a lower rate of 0.5 mm per day because all of them were smokers, and later increased to 0.75 only after the radiological confirmation of a good regenerate. Post-operatively, all the patients were encouraged range of movement. Follow-up was done at 3 weekly interval for 2 months, and later followed up at 6 weekly intervals for acutely docked cases, and the patients who required bone transport were followed at 3 weekly interval till the time of docking. The apparatus was only removed after clinical and radiological signs of union after clinical testing. The outcome measures were analyzed with the Asamicon scoring system, and the bony results were analyzed with the Asami. and the functional results were analyzed with the DASH score. I think the slide is missing over here. The complications were assessed using the Paley's criteria. The results, the bony results were analyzed with the Asami scoring system, where 7 cases had excellent results and 3 patients had good results. Sorry for the misplace of the slide over here. The functional results were analyzed by the DASH scoring, and the average DASH score in the study was 9.7, and it ranged between 0 to 26.7. And coming to the disability assessment, minimal disability was present in 9 patients and only 1 patient had moderate disability. And coming to the complications were assessed by the Paley's criteria. Only 5 patients had pin tract infection, which was a problem. There was only 1 patient with obstacle, that is pin loosening, where I had to intervene and change to a wire configuration. There was 1 patient who had deloid consolidation, for which no intervention was done, and no neurological issues were encountered in the series. Coming to the cases, this was a 46-year-old male patient, multiple times operated with all graft sites exhausted. I did a distal humeral corticotomy and proceeded for transport proximally. And these are his radiographs, immediate post-operative radiographs. The sequential radiographs showing good transport in progress, and then finally good consolidation of the regenerate and good union at the docking site. These are the 14-month follow-up, and he has good functional range of movement. Case 2 also was a recalcitrant non-union case, operated more than 8 times, which included 1 failed Elizarov as well. And here I just acutely docked it. And this is the happy patient with the fixator on. I did face some issues. There was some delayed union of the non-union site. So here I proceeded with accordion maneuver. It went on to unite well, and this is a 4-month follow-up. Case 3 is of a 26-year-old male who was operated multiple times, again with plating, got infected. I accepted 2.5 centimeters of shortening, acutely docked, and good functional range of movement. Case 4 is of an 18-year-old female patient with a sequestrated distal and radius, and the plan over here was to do the radial transport from proximal to proceed distally and then fuse the joint, fuse the wrist. And these are the sequential radiographs with good regenerate and good consolidation and good union at the fracture site. And these are the 11 months follow-up with pretty good functions. The last case was one of my most challenging cases, and here it was similar to the case 1, proceeded with a distal humeral corticotomy and transport, but there was pin loosening and I had to change it to a wire configuration. In spite of that, the patient was quite comfortable. And these are the sequential radiographs. You can see good consolidation of the regenerate and good union. And these are the 5-month follow-up with good functions. To conclude, in this era where we see infected non-unions and various advances in orthopedics, we still encounter these cases. The versatile solution to it is the Elizarov external fixator, because it helps in infection control, gives a reliable union, and can even correct associated deformities. And this assumption that the upper limb Elizarov fixator, ring fixator in the upper limb is cumbersome is a myth, and following good Elizarov principles gives us excellent outcomes. It still stands the test of time. Thank you.
What was your preference of corticotomy in humerus?
Pardon, sir? Preference of corticotomy?
In humerus, no infected non-union humerus, you have done in corticotomy. What would be the preferred site? And
yeah, so it depended on the type of non-union I had. If I had I would prefer a distal corticotomy always, because the proximal has a difficulty. This abduction contracture can happen if there is pin loosening. About 5 to 6 centimeters, just above the supracondylar notch, metaphyseal region mostly. How do I prevent radial nerve injuries? So my wire fixation. Yeah, yes, sir. So my pin formula is for the distal level. I always used anterolateral to posteromedial chance pins, sir. And when I'm below the spiral groove, I always used a posterior pin. And for the upper levels, I used anterolateral to posteromedial pins and a lateral pin. So that way, I always avoided the radial nerve. Hence, I did not encounter any neurological issues.
I want to know that usually all the persons they do below tuberosity, upper end of that.
Yes.
That area is very, very vascular. Number 2.
Yes, sir.
There is no chance of any nerve injury.
Right.
Because where you have done that, that is the common site of the nerve injury because
Yes,
the nerve is passing there.
Yes, sir.
So what is the problem in the upper end?
I do not say there's a problem in the upper limb, sir. My cases which I showed you had a gap non-union in the proximal level, and the proximal segment was way too small for me to do a corticotomy. Hence, I had to do with a distal corticotomy. Otherwise, I have no regrets in doing a proximal humeral corticotomy as well. It always depended on the case that was present.
Anybody else any questions? Thank you, ma'am.
The topic for today is infective non-union of tibia treated with acute docking and lengthening. We have an analysis of 20 patients. So infective non-union of tibia, infected non-union of long bones is a common problem. Among them, we come across a lot of infected non-union of tibia. There are several surgical managements available such as bone grafting, free tissue transfers, antibiotic cementing and Elizero methods. Among them, Elizero method addresses all the problems simultaneously. The stability of the fixation and provision for the bone transport allow the bridging of the bone defects, limb lengthening, early weight bearing and joint mobilization. In our study, we have described our experience in the treatment of infected tibia non-union by bone transport using Elizero external fixator. Ours is a prospective study and we have two hypotheses. Elizero methods in the treatment of infected tibia non-union can acquire satisfied effects in bone results and functional results, and radical debridement is the key step to control the bone infection. Our aim was to evaluate the effectiveness of the treatment of infective non-union of tibia by acute compression and lengthening with Elizero frame fixation. Eligibility criteria was patients more than 18 years with no neurological deficit and with no peripheral vascular disease. Ours is a 3 years retrospective study conducted at our institute. From June 2021 to November 2023, the average number of surgeries, previous surgical procedures in our patient was 2.2. The average length of bone defects after radical debridement was 5 centimeters. And these are the sites of the tibia non-union. Majority was in the middle third to distal third. Our results were analyzed using the Asami scoring system. This is our patients and methods. Majority had a road traffic accident. This is our preoperative data. And we had a purulent discharge in our 15 patients. We have sent culture and sensitivity prior to the surgery. And majority of the organism isolated was Staph aureus. We have taken an incision on the previous surgical scars. We have done a radical debridement and removed the dead bone. And we have debrided the bone until the paprika sign was available. We have done an acute docking. All our patients received a course of sensitive intravenous antibiotics for 1 to 2 weeks and 2 weeks orally. We encouraged all our patients to do partial weight bearing with walker and perform isometric muscle and joint motion of exercises. Latency period for lengthening was 7 to 10 days and the rate of distraction was 0.25 mm per 6 hours. So our evaluation and outcome was bone transport time, external fixation indications and complications. All our radiographs were reviewed every 2 weeks during the distraction period and monthly during the consolidation period. Our results, mean follow-up of the result was 23.12 months. All our patients achieved bone union and there was no recurrence of the infection. Our mean external fixation index was 1.3 months and our mean external fixation time was 7.6 months. Our results were evaluated according to the Asami classification. So bone results were excellent in 12 patients, good in 6, fair in 2, and functional results were excellent in 11, good in 6, fair in 2, and poor in 1. We had common complication. What we encountered was pin tract infection. 3 patients had inflammation, which we have treated with empirical broad spectrum antibiotic. 1 patient had purulent discharge, and it was sent to culture sensitivity, and it was treated according to the report. And 1 patient had had a refracture after the removal of fixator, so we had done the redo Elizero. No patient had axial deviation. There was no loosening of wires, and no grafting was required. This is these are my case series. This is a 55-year-old male with infective tibia non-union. So we have done a radical debridement, acute docking, and a corticotomy was done. This is a 4-week post-op, 6-week post-op where you can see there is a good regenerate and there is a mineralization, and we can see consolidation at the fracture site. There is a 7 months follow-up and then there is a 9 months follow-up. This is a 1-year follow-up. The fracture has nicely united at the docking site and also at the corticotomy site. This is the final functional outcome. So, this is a case 2 of 61-year-old female with infective non-union tibia. So we have done acute radical debridement, acute docking and corticotomy. Patient followed to us till 4 weeks and suddenly patient lost the follow-up for 7 months. So we had encountered a premature consolidation of corticotomy, but patient was comfortable and she did not want to undergo another procedure. So we have followed her with the serial radiographs. This is the 11 months post-op, and this is the final 15 months post-op. Though there is a shortening more than 2.5 centimeter, patient has an acceptable functional outcome. She was comfortable and she had no pain and no stiffness. This is a 26-year-old male with infective tibia non-union with a flap cover. The flap was infected as well. So we have done a flap elevation debridement. This is an immediate post-op where we had an acute docking and then we have done a corticotomy. We waited for 3 months in this case because this patient had 3 surgeries prior to our surgery and one among them was Ilizero. So we have done second time Ilizero for this patient. So this time we waited for the acute docking of the fracture to get united. So 3 months after that we have done corticotomy for lengthening. This is our 4 weeks follow-up. This is an 8 weeks follow-up with good regeneration. This is a 4 months post lengthening and this is a final 7 months follow-up. This is a 6 months follow-up where you can see that the corticotomy site has nicely consolidated and the docking site has also shown a bony union. And this is the final outcome of the patient with good knee range and there is no limb length discrepancy. So our conclusion is Ilizero method in the treatment of infected non-union of tibia gives satisfied bone and functional result. If we do a radical debridement and if we follow the patient properly.
May I ask you, when you do docking site, why you didn't do deformity correction in docking site place? I mean, why you not correct in Ilizero frame bone fragments at the same time with docking site? Because all of the cases which you showed, yes, finally is good. Finally is everything is fused as union, but on every cases have some dislocations. Some bars. Why you didn't do that in the docking site surgery? It's easy.
He's asking that at the docking site, did you take some steps or what could have been done so that there is no varus or varus angulation? Okay, don't get scared. See, that was not done, but in her cases, you see that okay, there was not a perfect, but there was at least 50% of contact was there. So minor thing she has not done it. Actually, the paper was nice, but one advice I give you, you have to make it slim and trim. Means your slides are totally full. So you should not have more than 6 words per line and not more than 6 lines. So then it looks good. But if you fill it fully and then start reading it, then a person gets lost. So otherwise it was nice. Okay?
Thank you, Dr. Tarnum. I'd like to call upon Dr. Kritika.
I'm Dr. Kritika Shetty. I'll be presenting a case report on fixed flexion deformity of proximal and distal interphalangeal joint of the hand corrected by Jess. We had a 28-year-old female who came with a deformity of left index finger since 4 years, with associated history of abscess near the dorsum of the index finger 4 years ago, which drained spontaneously. She had not consulted a doctor or undergone treatment. The deformity gradually progressed to the present state over a period of 2 weeks. Her functional limitations were that she could not cook and she could not make rotis, were her most important complaint. On examination, she had a flexion deformity of the left index finger, an irregular scar over the dorsum of the PIP joint which healed by secondary intention, fixed flexion deformity of around 90 degrees at the PIP joint and 80 degrees at the DIP joint. There were no neurovascular deficits. We went ahead and took a plain radiograph which showed no bony irregularity but early arthritic changes in both the PIP as well as the DIP joints. We went ahead and planned for deformity correction by just distraction. Under wrist block, a distraction frame was constructed using 2 K-wires of 1.8 mm, which was passed one through the shaft of the proximal phalanx and the other to the base of the distal phalanx. The pins were placed parallel to each other. 2 just distractors were connected on either side of the index finger to construct a bilateral uniplanar assembly. The lengthening rods were placed on the volar aspect to provide both distraction and extension. The fixator was positioned far enough away from the skin to accommodate the swelling. So this is the post-op radiograph and these are the clinical images. Post-operatively, controlled graded distraction was started 3 days after the surgery at 1 mm per day with monitoring of neurovascular deficits. The patient was trained to do the distraction and pin track care herself at home and was reviewed weekly until correction was achieved. Deformity correction was achieved after 35 days of daily distraction. The assembly was held in static position for 3 weeks to allow soft tissue maturation in the corrected position, and the extension gained was 80 degrees at the PIP and 70 degrees at DIP joint. At follow-up, she was free from pain and regained her daily activities. This is post-op clinical image at 8 weeks. So a single stage removal of frame was done under ring block, and the finger was immobilized in an extension cord with physiotherapy, with simultaneous physiotherapy. This is a follow-up at 3 months, and patient had corrected deformity in acceptable functional position. We used quick dash score.
What was the flexion in this case?
So there was no active flexion at the end of 3 months. It was fixed in functional position, sir. Acceptable functional position.
See, I'll tell you, I have long experience of doing all these cases. And I have been trained by B.V. Joshi also. I had a privilege to be trained by him. Now the issue is that this works. Okay.
Functional outcome was done using the quick dash score, which was 61.4% preoperatively, improved to 2.3% post-op, and a fixed flexion contracture of PIP and DIP joint of a single finger can reduce functioning of the hand. It can vary from minor cosmetic problem to a crippling deformity, and open surgery such as capsulotomy, tenolysis is often discouraging due to wound healing complications, which will require subsequent skin grafting, and worsening of stiffness occurs with prolonged immobilization and splintage. So my conclusion is that we have found good result in correction of deformity by GES, which is easy, simple, versatile and effective in reducing contractures of PIP and DIP joint.
So what I was talking that when you combine this with the release of the volar plate, I used to do without doing that, but once I started releasing the volar plate and then applying GES, and there is a hinge type of fixator available. Because straight, sometimes what happens when you are distracting, it can subluxate it. So it's you get a hinged one, but you see the result if you do the volar plate release, you will get flexion also. Doing with this, yes, there is a problem that you might not get flexion. So combine these two procedures, you will get good results.
So told that there is a spring-loaded external fixator. So you have not. Second thing, when you have done the extension of the finger, how you manage the skin?
Sorry, sir.
Skin, because there is a contracture of this, one of the case. So how when you do that, you have to release the skin. What do you do for that?
Here in this case, we haven't done anything, sir.
How it's possible? It's just what we do a lot of that. Just you cut that. Either the skin will regenerate plastic. That you have to do. Without that, how you going to do? I don't understand.
When you are releasing the molar plate, you do a Z plasty.
Yes.
Second important point is that distraction is not 1 millimeter per day in these cases, it is less finger. If you distract 1 millimeter per day, it might cause vascular problem. So initially you have to take a 0.5 millimeter per day and then you...
But weekly assessment was done for neurovascular.
I understand, but you should reduce the distraction of this case.
Yes. Thank you. Good morning to respected chairpersons and my dear colleagues. I will be presenting a paper on long gap infected non-union of tibia managed by acute in vitro fibular transport in with ring fixator. It is a case series. I acknowledge all my professors of my college for giving me opportunity to go and operate in their units. The study is a retrospective analysis which goes back to October 2018. I have done a follow-up up to January 2024. 7 cases of infected non-union of tibia have been studied. The aim and objective was to know the feasibility and success of acute in vitro fibular transport in management of long infected gap non-union of tibia with ring fixator. So the indications as per the literature and also in my condition and also in my patients were bony loss, bad skin condition to augment the remaining tibia with bone loss, or in conjunction with bone transport to reduce the duration of transport. In my cases specifically, I have done taken the decision for a non-compliant patient, destitute or orphans, loss of follow-up, bad skin condition and medial bone stock intact. So this was the need for study. I wanted to know whether the decision which I have taken long back was good or not. So the prerequisites in these cases were acceptable blood supply and sensation of the foot was intact. These were my materials and methods. The site was proximal distal third junction in 4 and middle distal third in 3. Average gap was 11.4 centimeter. Staged procedure was done in 5 cases. Plastic surgery intervention was done in most of the cases. Some of them had comorbidities as well, and one patient was IV drug abuser. Most of them had staphylococcal infection. So I took up the infection and non-union severity score from this article, and I had an assessment tool as well, that is non-union severity score and infection severity score, where average NUSS was 63.6, which is quite high. Infection severity score was 66, which is also high. I have assessed the patient scoring by EQ-5D-5L scores. Pre-operative average was 23. And the follow-up scoring was by Asami score, functional and bone results. So if we see this graph, the grey graph represents this total score of the patient, non-union and infection, which is quite high in most of the patient. And when we see the last dark blue and the brown ones, they represent the Asami scoring, which is really good even though the total score was really bad in these cases. And the yellow, blue and green represents the decline in the EQ-5D-5L scoring, that is decline represents a good scoring. So immediate post-op EQ-5D-5L really increased a lot, that is or reduced, or it is very good from 22 to 13, which is really a good score. And 6 months after frame removal, it became 10. Average frame time was not that bad, it was just 44 weeks. And I have 2 patients of 5 years follow-up, and most of them are less than 5.
Asamicon results were excellent in 4, good in 1 and fair in 2, and functional results were excellent in 5. So this correlated very well with the review of literature. So case 1, this was 19-year-old male with infection severity score of 76, non-union of 46. The patient had a tubular sequestrum which was debrided, frame was applied, and I did a staged procedure. Here we can see lot of callus there on the anterior and posterior part of it. So corticotomy also was done to achieve some length, and fibular transport was done in the second stage. This was a side-to-side fibular transport because I got lot of callus on the medial and posterior aspect, and this was intra-op picture where I used K-wires to joystick it, and this was immediate post-op. We can see the entire cavity was filled with callus, and this is at 6 months follow-up. Patient is mobilizing really well, and this is at 4 years follow-up. We can see 2 tubes literally forming well, and this is the recent follow-up of the patient at 5 years follow-up and the x-rays. So another case with non-union severity score and infection very high, intra-op picture again tubular sequestrum, and corticotomy also was done for this. He had also had a fibular fracture, and again a follow-up of 4 years and 5 years. Patient is walking well. Another case, chronic alcoholic and recently expired because of tubercular meningitis with high scores, staged management, final follow-up of 1 year. I have only 1 year follow-up because after death patient expired. So this can be a reasonable option to salvage the limb, especially in these kind of cases. So the drawback is my case series are retrospective, very less number of patients I have. My conclusion would be acute in vitro fibular transport is helpful and alternative treatment modality, especially in long segment bone loss, non-compliant patients where we may not have a proper follow-up, patient with lot of comorbidities, bad soft tissue condition after multiple surgeries. Ring fixator is an excellent treatment modality for such procedure. It ensures union, eradicates infection, and provides good functional outcome. Thank you.
Yes. My question is, do you use femur graft like free flap or like by result, like by gradual transporting?
So normally gradual transport is accepted, but what happens in some conditions in my hospital is we may not see the patient after the surgery. So what I did is, if I have to have a limb salvage, so I did an acute in vitro fibular transport with olive wires, and I pulled it. I had to open complete on the lateral aspect, see and make a draft and fix it, so that after the suturing, even if I use him for follow-up for 2 years, I am really happy with it.
Yeah, and you used like a free graft or with a vascular graft?
It's a vascularized and muscle. Both together I have transported. Yeah. Normally I prefer corticotomy and the transport, but in some conditions I have done exercises. Yes.
Thank you, ma'am. Any other questions? I'd like to call upon.
So this is just an overview in which indications of LRS which can be used. I would like to disclose that there is no conflict of interest. All of the cases are aborts except one, and we do not propose LRS to be superior to LE0. LRS is an assembly in which clamps can slide on a rail, and it is primarily used for tibial diaphyseal lengthening. But we will show you some of the cases in which we have used LRS for different indications with varied success. So we have used LRS for all these cases, and I will be showing you one by one all these cases for LRS in forearm, osteotomy, for orthodosis, and for tumor resection. So this is the first case, infected gap non-union tibia. We did resection, fibulectomy, raised an LRS, did a corticotomy, and then transport was done. Regenerate was formed, and these are his follow-up X-rays, and this is the final X-ray in which LRS is used for infected diaphyseal non-union of tibia. So that's the final X-ray of the patient. So this is an again metaphyseal fracture of tibia, which is an infected metaphyseal fracture gap non-union. Patient came with this, we applied an LRS, did a transport, and we got a union for this patient. Next is distal metaphyseal non-union, infected non-union of the tibia in which fixator was applied and patient came to us with this type of clinical picture. We applied an LRS, did a corticotomy, did a bone transport, and then union was achieved. Some cases of infected non-union femurs. This is a infected non-union, nailing was done, infection was there, so we put an LRS, did an compression, and union was achieved. So metaphyseal infected non-union of femur. This was a patient of 6 months non-union, plating was done, there was an infection. We put an LRS. Initially we thought with antibiotic beads we can get off with the infection. So I didn't remove much of the bone, but infection didn't subsided. So I took out the bone, did an corticotomy, did transport. I was lucky to get a lateral union, but medial there was not union. So I put a tricortical graft over there and union was achieved. Patient came to me, patient was so aggressive, he went to his place and did physiotherapy. He did physiotherapy to get a knee range of motion. The physiotherapists were too enthusiastic. He came to me with diaphyseal fracture at the regenerate. So I put a plate and then union was for this plate. So infected non-union diaphyseal of humerus, we applied an LRS. This is the infected plate. LRS was applied and then union was achieved for. For distal metaphyseal fractures of infected non-union humerus, this is a patient, plating was done. Patient has got a foot wrist drop as well during the primary surgery. So we put an LRS, we did an modified Jones transfer for the patient to get the wrist. The wrist extension also, and then the union was achieved and LRS was removed and he has got wrist function as well. For proximal metaphyseal fractures of humerus infected non-union, we put an LRS, and that's the follow-up X-ray. We give a test for union before removal of LRS. So in some open fractures, tibia open fractures, initially these were treated with LRS. Some type of femur open fractures treated with LRS. In chronic osteomyelitis of the femur, this is a chronic long-standing osteomyelitis of the femur. We have used LRS for these type of patients. This is chronic osteomyelitis of the tibia, 8 years male child. We put an masculine technique cement spacer initially. Then fibular grafting was done, but initially one side united and the other side did not united. We put an LRS, did an compression, and then the final follow-up of the patient. We put an LRS in forearm also. This is a neglected Montagia fracture dislocation. So the concept here is you do a lengthening of the ulna. So we did a lengthening of the ulna, and then the radial head fall back and the patient has good range of motion. In osteochondroma of ulna, the concept is same, the radial head is jetting out. So you do an osteotomy of the ulna, dual lengthening. So this is how the radial head fall back, but we were skeptical, the radial head will dislocate again, so we did a belt out surgery for this patient as well. So some of the osteotomies, this is an infected THR. Girdle stone was done for the infection. For this we did a PSO with an LRS. This is a pelvic support osteotomy which was done with an LRS. See, the regenerate is forming over there, the patient is still in follow-up. This is a superior procedure. The Palais describes the application of a plate for this patient, but plate for so small patients is not available. So we did it with an LRS and fixed the osteotomy at the level of the femur with an LRS. And Perthes varus osteotomy, which has been fixed and treated with LRS. This is again Jhunjhunwala, which is treated with LRS. This case is not mine, I have taken from someone else. This is valgus osteotomy for infected non-union of proximal humerus. Valgus osteotomy is being done with the fixation with LRS. For coxa vara, valgus osteotomy is indicated. This is being treated with LRS. Osteotomy is done, and this is the final follow-up of the patient. Some orthodosis, knee orthodosis, we are being treated with LRS. We can combine the LRS with external fixator below as well as across it when the fixation is poor. So this is, we have combined the LRS with Lizero as well. This is again an infected non-union at the ankle side. We have applied an LRS, taken the fixation in talus and calcaneum, and along we have combined it with a metatarsal pin and fixed with the fixator to increase the fixation. We have used in GCT femur. And this is again my last case. Probably this was the patient came to me with this type of clinical picture. I did multiple flaps and did an corticotomy, and transport was done. And the final picture of the patient is this is the final picture. I could save the limb. Hypophosphatemic rickets. Just my last slide. Sorry. So why limb reconstruction system? It's mechanically give high stability and early mobilization. It can be applied at rigid or dynamic mode, and it gives temporary and definitive fixation both. Patients with high compliance, it's light monolateral fixation, easy compression and distraction for the patient, shorter hospitalization, less economic burden, and for surgeons, simple surgical technique, short learning curve, easy soft tissue management, and less interference with the radiographs. Drawbacks are it lacks three-dimensional stability. It's not superior to Lizero because it's lack modularity, and mid-track infections are losing it. I thank everyone for patient listening.
Thank you, sir.
Dr. Saurabh, is a nice presentation, but you have not shown us in THR case whether you have done the girdle stone, you have done the pelvic osteotomy, but there is no final result.
We have done lower osteotomy at the lower level.
I mean to say, you are presenting the case.
Yes, sir.
You should show the point.
Still in follow-up, sir.
Then those cases you are in follow-up. You should not show here.
Do it, sir.
Minimum one year follow-up certain things. You have to show us. There is no follow-up. There is no sense.
The article, the study is just showing indications of LRS. That's it. I just want to highlight that we can do LRS from these indications.
We are applying your parents good osteotomy. The regulation is so much that it's very difficult to work with persons.
Angulation depends on you do a reduction where the point ischial velocity touches.
The osteotomy is done at the level of the ischial velocity.
Yes, sir. Reduction the whole of the point where ischial velocity touches.
Anyhow, there is no final result.
Today I am presenting a case of tibia gap non-implant failure treated with limb reconstruction system. This is the X-ray on presentation which show the shaft tibia fracture with gap non-union and so skeletal margin with implant institute. Introduction. Non-union of tibia femur common in clinical practice. Some coexisting problem usually complicate the non-union, including persistent infection, bone soft tissue loss, limb inequalities. Many times, compound fractures are treated with external fixator or internal fixation, nail or pipe plate. Recently, limb reconstruction system has been used to treat non-union after resection of infected and sclerotic bone and fracture ends. My case is a 25-year-old female have a roadside accident. This patient was operated somewhere else with open reduction time fixation with a conventional plate. After 2 months, because of re-trauma, patient plate bend and fracture site doesn't heal. And patient come to me after 8 months, present with complaint of deformity and unable to walk and limb discrepancy of 5 cm shortening. On examination, patient present with deformity over affected side and non-tender, non-mobile and TB palpable. Routine blood parameters are normal. We have planned the procedure, incision, soft tissue release, followed by implant removal, deformity correction. We do acute docking and proximal tibial corticotomy for lengthening, and then application of LRS fixator. This is the zigzag incision given over the interlateral aspect of leg, and followed by soft tissue release, then implant removal. This is the immediate post-op X-ray showing proximal corticotomy, and this is a post-op 1 month X-ray showing distraction site. This is post-op 3 months. During this time, we have to do realignment of the Sanchmen for angulation correction. This is the post-op 6 month X-ray, and we have applied PTP cast after that and do implant removal. And after 1 year follow-up, patient is able to walk, squat, and cross-leg sitting. We have done distraction after 7th day post-op, and physiotherapy has started with walkers, and we do filtrate dressing and cleaning with boiled iodine. After 6 months, LS removal done. Discussion. Management of non-union is always challenging to orthopedic surgeon. It requires proper expertise. Improper management lead to multiple surgery. The goal of treating a complex non-union is to achieve a fully functional limb without any deformity, with union at fracture site, with no residual infection. The biology of the compression and restriction osteogenesis of the bone and soft tissue is basis of treatment using their fixator. Advantage is it is a less invasive, early weight-bearing candle, less infection, less blood loss. LRS is not suitable for fracture with deformity in 3 dimensions. And after acute docking and lengthening is suitable for defect up to 3 cm in tibia and 5 cm for femur. Mean treatment index, that is was 1.7 month per centimeter, which is comparable to other study. And the duration of treatment index mainly depend upon the size of gap, shortening, and type of distraction we have done, either monofocal, bifocal, or trifocal. Conclusion: rail fixator is promising implant for the management of complex non-union of tibia. Main advantages are lighter, robust frame, greater patient satisfaction, and learning curve short and less complication. Thank you.
Thank you. Any questions from anybody?
My today's topic, paper presentation is management and outcome of gap non-union of tibia by Elizarov fixator under the guidance of Dr. Jayan Sharma and Dr. Prashant Upadhyay sir. So to move on to introduction, with the advancement of industrialization and the development of the transportation industry, there is increase in incidence of complex fractures of long bones, especially tibia, in recent times. Defect in bone can be due to trauma, infection, or any tumor. There are 2 major problems in gap non-union: bone loss and non-union. Both should be addressed, both should be managed at same time. There are multiple techniques used to manage tibial non-union with bone defects, which landed up in amputation. However, after the development of techniques such as Elizarov, the rate of limb amputation has reduced. Aim of the study is to prospectively assess the radiological and functional outcome of management of gap non-union of the tibia using Elizarov ring fixator. We have studied in 20 patients. Study is prospective in the tertiary care hospital. We have included all the patients of gap non-union between 18 to 60 years who are psychologically stable and are willing to give and provide the written and informed consent. We have excluded the patients with acute fracture, pathological fracture, psychiatric patient, and patients who are not willing to give consent. We have majority of the patients were in the age group of 31 to 40 and 41 to 50 years, and the mean age of patients were 39 years. 17 of our cases are males and 3 of them are females. According to the Assamicon scoring system, the bone results were excellent, and excellent and good bone results together were considered as good outcome, that is in 82%. Functional outcomes of on the basis of the Assamicon scoring system, 80% of the patients were considered to be excellent and good. But we encounter the numerous of the complications, most common being the pin tract infection, dermatitis, equinus, etc. This is the case. A patient 40-year-old with history of RTA 9 months ago. Patient presented to us with skin loss and with external fixator X2. This is the pre-operative X-rays. we have radically debrided and there was skin loss. For that we have planned a split skin graft. After this is the immediate post-op radiograph showing the debridement, followed by corticotomy at the metaphyseal junction, unifocal corticotomy, and then bone is transported. This is the good callus seen in the follow-up X-rays, and this is the clinical picture showing the good healing at SSG site. This is a post-removal of Elizarov X-rays showing the good consolidation. This is the second case, 47-year-old male with history of RTA 1.5 years ago, presented with difficulty in walking. We have planned Elizarov fixation. In follow-up, there was hourglass appearance at transport site. We have asked patient for surgery, further surgery, but patient denied for any further treatment. So we have continued with the fixator. This is the follow-up X-rays, and this is the post-removal X-rays with good consolidation, and the hourglass appearance has been consolidated on its own. But we encounter a complication, dermatitis over the distal leg post-removal of the frame, for which dermatological opinion was taken and it was subsided. This is the full range of motion post-removal. The patient can able to sit cross-legged as well. Third case, 39-year-old male with history of RTA 9 months ago with external fixator XC2. Radical debridement was done, followed by ring fixator application and corticotomy. Following corticotomy, transportation was done. These are the follow-up X-rays showing callus formation. Good consolidation seen in late follow-up as well. And this is the post-removal X-rays. We have applied PTB cast after the removal. These are the good range of motion at the knee. But we encountered several complications as well, such as most commonly pin tract infection, mostly grade 1 and grade 2 pin tract infection as per the Checkett's and Otterman classification, and dermatitis for which dermatological opinion was taken, and all over complications were subsided with time. Though the study was not free of complications, all the patients of the study were satisfied with the results. Elizarov ring fixator is a good treatment option in tibial non-union with bone defect. It helps in control of infection as well as restores the tibial length. Moreover, Elizarov fixation helps in early mobilization and decreases morbidity due to immobilization. Thank you.
Thank you. Since we are still waiting for the check.
Myself, Dr. Sunil Raikar, PG in Valley. My paper is on functional outcome of atypical osteotomy for Jhunjhunwala. Introduction. It was first introduced by Jackson and Waugh in 1961. The atypical osteotomy has become popular by commentary since 1965 as a treatment modality for medial compartment osteoarthritis of the knee with varus deformity. The goals of HTO are twofold: to reduce the knee pain by transferring the weight-bearing loads to the relatively unaffected lateral compartment in varus knees, and also to delay the need for knee replacement by slowing or stopping the destruction of the medial joint compartment. The objective of my paper was to assess the functional outcome of medial opening wedge atypical osteotomy with rigid fixation after the correction of mechanical axis of the lower limb. Materials and methods I used were I could get total number of 3 patients. Inclusion criteria that I used was the patients that presented main symptom of pain in the medial compartment of the knee with associated varus deformity. And exclusion criteria was the bicompartmental knee osteoarthritis. The preoperative planning included me using the Miniachi method for medial opening wedge atypical osteotomy. And after the achieving the wedge, the deformity was corrected using HTO plate. So the preoperative workup included routine blood investigations in the scanogram, knee X-ray, all that. Follow-up period was 6 months, and I used Tegner Lysone knee score to assess the functional outcome. So the preoperative planning was the scanogram that I've used here. The Mikulic's weight-bearing line was projected through the lateral compartments of the knee at the Fujisawa point, and the correction angle was generated at the hinge point. subtending the current and proposed ankle centers. The opening wedge was plotted to measure an opening distance, and the incision was made in the midline between the posterior-medial border of the tibia and medial aspect of the tibial tuberosity. Sartorius fascia is cut and retracted medially to expose the MCL. There was a study which showed the safe zone of the fibula where the hinge point can be used. So the safe zone is an area between the tip of the fibular head and the remnant of the fibular head epiphysis line. And the 2 K wires were placed and 4 cm below the medial joint line towards the safe zone, and osteotomy was done. The thin osteotomes were used to gradually open the osteotomy to the desired length. These are the some advantages of doing medial open wedge osteotomy. That is the ability to correct the alignment in 2 planes. No need for fibular osteotomy. Little risk of peroneal nerve injury. No limb shortening, no bone loss. Easier conversion to arthroplasty if needed in the future. And ability to adjust the amount of correction during the surgery. And some of the disadvantages are that there may be a need for bone grafting, and there is a risk of delayed union or non-union. These were my cases. There are 3 cases. The first case was a 30-year-old male with complaints of pain in the left knee since 6 months. These were the intraoperative images with the fluoroscopy image. And after the correction, this was the post-operative X-ray, both scanogram and the X-ray, the clinical picture. Similarly, case 2, 38-year-old male with complaints of pain in the right knee, and case 3 with a 42-year-old male. So the results were like this. The lysome knee score that I used for the case 1 gave 60, 77 and 73 for the respective cases. And so the mean lysome score happened to be around 70. And a 6-month post-operative follow-up showed improvement in the technical scores. The conclusion is following the satisfactory correction of the desired mechanical access line of the lower limb, there will be improvement in the functional outcome through technical lysome knee score can be obtained. Thank you.
Good afternoon. My topic is myself M. Aravindan. My topic is how we manage a case of infected tibia non-union treated with Elizaro using a bone transport technique in an intellectual disability person. Here is a case report of a 23-year-old male with an intellectual disability and mute since birth, presented to our hospital with the complaints of pain and pus discharge over the distal one-third of the left leg. He had underwent 4 major surgeries for the past 2 years before presenting to our hospital due to an injury experienced. This was the initial X-ray where he had an alleged history of road traffic accident and sustained left leg compound injury with the distal one-third of tibia and fibula fracture. And after that, he had underwent IML nailing with a wound debridement. Then he, after 1 month of post nailing, he developed a pus discharge. Then he was started on IV antibiotics and debridement was done after 1 month. And again, he developed a pus discharge, which was after 6 months, where IV antibiotics and debridements were done. And after that, 10 months of the post-nailing implant was removed, and wound debridement was done with the ankle spanning external fixator was applied. Then patient was in external fixator for past 3 months, then converted to removed and converted to plaster Paris cast for a period of 9 months, which was total of 1 year. During this period, patient was not in a proper follow-up. This was all done in outside hospital. Then following which, on August 2021, patient underwent a non-vascularized free fibula graft transfer with the screw fixation and bone grafting. So this was the present condition which was presented to our hospital. Like patient was presented with a pus discharge with a fibula, 4 months of fibula graft and a bone resorption, and a screw loosening out was present, which was removed easily. And the problems which we came across was the skin condition, poor skin condition, and the infection of MRSA, and a shortening of a bone length, limb length was 4 cm and bone gap of 4 cm. total around 8 centimeters. Then intramedullary fibular graft was present, and ankle equinus deformity was present at 30 degree with a foot cavus deformity and clawing of the toes. So our plan was a two-stage procedure. First stage is like wound debridement of the intramedullary reaming and remnant fibular removal with Elizaro fixation and tendocles percutaneous release and the stainless release. And stage 2 is a proximal tibia corticotomy plus fibular osteotomy and toes clawing release. So this was first we released a percutaneous tendocles was released with a stainless release of the for foot equinus correction. Then we have underwent a wound debridement and intramedullary reaming of with the remnant fibula graft was removed and at the non-union side. Then we did a distal ortho fibulectomy with the Elizaro fixation of the left lower limb. And after a period of 1 month, with the walking training, with the walker support, we after settling the infection, patient underwent a left proximal corticotomy, tibia corticotomy with the Elizaro realignment and a tenotomy of the grade 2, second, third, and fourth further. Then this was the check X-ray after 2 weeks of the proximal tibia corticotomy. The transport was initiated and continued for 3 months until the disalignment, which is the 4 centimeter of non-union gap and a 4 centimeter of limb shortening was achieved with the distraction rate of 1 millimeter per day. And this was the serial X-rays taken after every 2 weeks. And this is at the 5th week. And this is the 7th week. And this is the 10th week where you can appreciate the class formation. So at 12th week, distraction was stopped after achieving the desired length to bridge the non-union gap. Follow the X-ray was of proximal and distal ends of the tibia in contact. So after the 2 months of completion of the consolidation phase, showed a good signs of union on the anterior and lateral cortex with the insufficient union on the medial and posterior cortex. So what we planned was initially was the accordion maneuver. Accordion maneuver, as like earlier said, it's a alternating. It's a procedure for a defect in the non-union gap. So it's a how we did. It's like alternating compression and distraction maneuver at a rate of 0.25 millimeter twice a day. Twice daily for 7 days, follow up for a rest of 3 to 4 days, and cycle repeated twice, and then we perform again the opposite maneuver. Finally, the compression adjustment on every third day for a month. So even after this maneuver, we couldn't, still callus formation was not appreciable, so we planned for bone grafting. At last, we did a bone grafting, and from there we took a bone graft from the iliac crust and equal limb length was achieved. So post-operatively, after a period of after the period of Elizaro exit, patient was advised for a strict non-weight bearing walking, and below knee POP was applied for 1 week, during which regular dressings were done at the pin track sites. After a week, patient was put on a below knee pedal and graft cast and was advised for a partial weight bearing for the past. Coming on to the discussion, initially patient was advised for below knee amputation, then Elizaro fixators was applied. Below knee amputation was advised at the outside hospital, sir, due to the poor stability, proper stability and antibiotics were not used. So we have planned for to prevent the eradication of the infection. We started to give Elizaro ring fixators, sir. And this was the clinical picture.
Step the fibula transplantation is by you or by other doctors?
No, by other.
By other hospitals. Okay, and then later on you transplant the fibula from the another side to here.
Yes, we did a fibula graft.
Yes.
They have in outside hospital they have taken a fibula graft and contralateral limb they have taken fibula graft and they have made a vascularized fibula graft they have kept in the DVCs.
After eradication of the infection, why if it is good for you for the shortening because it's fibula is shortage. So if after you make the short of the leg and perhaps it's best way for the late lengthening, I think it's much better.
Good morning, everybody. I'll be speaking about infected calf union of distal tibia treated by two-stage procedure using Elizarov external ring fixator. Myself, Dr. Anil Reddy, from Sri Balaji Medical College. My guide was Dr. Subramania Gandhi, sir. Here is a case of a 31-year-old male who came with a history of RTA 2 years back, and he has sustained injury that is a grade 3B contaminated open fracture of the distal tibia, followed which multiple surgeries and flap cover and a uniplanar external fixator was done outside hospital. This was the picture of the initial this thing, where the first picture we can see the infected this thing, where the uniplanar this thing was applied, and then and comminuted fracture of the distal tibia is noted. So for that, this is the time at which the patient was presented to us, where already the flap was already applied and a bone cement was also applied for the distal fragment. So the problems which we faced once when the patient came to us was the distal tibia infected gap non-union, the skin condition, equinus deformity, and the distal tibia small fragment, and a shortening of approximately 5 centimeters. So initially, what we went ahead was the proximal tibia corticotomy, and then we removed the bone plug which was there. So we initially thought of docking it, but then the gap was more than 4 centimeters, so we had to go with proximal tibia corticotomy and then limb lengthening with the Lizero. This is the post-op day 2 range of movement with the patient. Post-op day 5 after visceral distraction, this is the X-rays. After 40 days of post-primary surgery, we attained a reach rate of almost 4 centimeters. So the second surgery was planned, in which the tense nail was removed and bone grafting was done to the distal side. And this is the 3 months post-op image, where a good quality regenerate, that is 4.5 centimeter of regenerate was attained, and the limb is aligned, and the equinus deformity was corrected because of in the second stage. This is the clinical picture at 3 months, range of movements. And this is a picture 1 month before frame removal. This is when we went ahead and started dynamization. Initially, for the first 10 days, we loosened the rods, and for the last 2 days, we removed the rods and we asked the patient to weight bear and walk. This is him weight bearing and walking. This is 10 months post frame removal. We've almost achieved anatomical axis. This is patient walking after 10 months of frame removal. The final ROM which we achieved. So in conclusion, I would like to say this case underscores the Elizarov external fixator has a pivotal role in managing complex cases, providing a reliable tool for achieving favorable outcomes despite their complications. It's versatile in addressing bone transport, deformity correction, and controlled dynamization, emphasizes significance in achieving structural restoration and functional recovery. These are my references. Thank you so much.
From Saptagiri Medical College, Bangalore. So my title of the paper is Arthrodesis of Knee Treated by Elizarov External Fixator. My main author is Dr. Ashadel Shasar. I don't think so he needs an introduction. So coming to the arthrodesis definition and introduction. Arthrodesis is basically fusion of joints. Most joints can be fused. Common in the lower limbs is the knee and the ankle. Other joints include the wrist, finger, and elbow. Coming to the general classification, it can be done by intra-articular, extra-articular, or we can do both combined. Treatment options, like in case of arthritis, excision is removal of the joint, excision arthroplasty, which we generally do in the hip. Fusion arthrodesis is done in knee and the ankle. Replacement is arthroplasty, and we can do it by heavy or total. Hip reconstructive surgery by Elizarov, pelvic support osteotomy, varicization, and limb lengthening. Arthrodesis of knee includes, like we have done Elizarov external fixator,
but it can be done by turnoplasty, intramedullary nailing, plate and screw fixation, and compression arthrodesis. So material methods include, we have studied a total number of 17 patients, which include 8 septic arthritis knee, 4 giant cell tumor, 1 traumatic crush injury, 2 burn contractures, 1 soft tissue sarcoma, 1 infected arthrodesis. There were 9 males and 8 females, age comes to 19 to 79 years, average age being 41. This is our first case where patient had a giant cell tumor of the lateral condyle of the right tibia. This is a pre-op. This is a perioperative picture. So the procedure done for this patient was, tumor was resected, iliaco-external fixation was done, corticotomy was done, bone transport, delayed docking, and limb lengthening. So this is the post-op, and this is the patient. Next is a 24-year post-traumatic septic arthritis of left knee, for whom he was treated by iliaco. So this was, the photo was taken during the distraction period, and this is in the OT, and this is post-op X-ray, and this was after 3 months. This is a 15-year-old patient who had giant cell tumor of the right distal femur. This is the pre-op, and for this resection arthrodesis and for limb lengthening in this patient, tumor was resected and there was 15 centimeter shortening. 2 corticotomies were done in the femur and 1 in the tibia were done in the first sitting. 2 more corticotomies were done in tibia in the second sitting, and arthrodesis site was distracted. So this is the peri-op and this is the post-op. Femoral corticotomies, this is a picture showing immediate post-op picture. In this, we can see the proximal femoral regenerating, distal femur regenerate. We can see the arthrodesis at the knee and the proximal tibia regenerate. This is 3 years, 10 months post-op X-ray. Equinus also was corrected, which the patient presented with. This is another case where 35 years old giant cell tumor distal end of left femur, where curettage and grafting was done. This is after 1 year. There was recurrence of tumor post 1 year, 4 months, for which we applied iliaco-external fixator. This is the post-op photos. This one is a 25-year-old comminuted distal femur fracture. This is a pre-op photos where iliaco-external fixator was applied, and at removal, the patient was fine and he was smiling and he went back home. And he was put on POP cast. Results, knee fusion was achieved in 13 cases. Above knee amputation was done in 2 cases of septic arthritis due to uncontrolled infection. 2 patients with 3 knee joints awaiting for fixator removal. There was no, the best part of this is there was no case of tumor recurrence seen as till date. Limb lengthening achieved in all the 6 cases. Review of the literature, Charlie, 98.5% rate of fusion in 67 cases with primary arthrodesis. Purinens is 96% fusion rate with intramedullary fixation. Ossenbrook and Netherlands, arthrodesis of knee after knee arthroplasty using iliaco method. 15 cases showed 80% fusion. Results, we had excellent, good results from both clinical and radiological assessment in all the 15 patients out of the 17. Complications, there were pin tract infection in 2 patients and equinus deformity in 1 patient. Conclusion, take-home message is the iliaco-external fixator is a good device for knee arthrodesis due to following advantages. One is stable fixation, early mobilization, forward bending, correction of deformity, limb lengthening, and in infected knees. References. Thank you, sir.
Everybody, my paper presentation topic is a prospective study to determine the functional outcome of pylon fractures managed by different modalities. Introduction. Pylon fractures are fractures of the distal tibia that can range from low energy to high energy and produce a spectrum of articular and metaphyseal injuries. The term pylon was given by the French physician Destot, which means a pestle that was specifically club-shaped for mashing and grinding the substances or medicines into the mortar. The term plafond means roof and is a descriptive term for suggesting that the talus acts as a hammer or pestle that impacts and injures the tibial plafond. This is the X-ray of the fractures, and this is an image of the mortar and pestle. Now, distal tibial fractures represent a significant challenge to most of the surgeons even today and account for 3 to 10% of the tibial bone fractures and 1% of the lower limb fractures. Management of distal tibia pylon fractures remain controversial because of limited soft tissue cover, subcutaneous location, and poor vascularity. As a result of the disappointing outcomes of acute definitive management, staged protocol has been advocated, consisting of temporary external fixation spanning the ankle joint, followed by open reduction and internal fixation with plates and screws after the condition of soft tissues have improved, usually over 2 to 3 weeks after injury. The plan that we follow in pylon fractures is usually span, scan, and then plan. Anatomy. The ankle joint, also known as the talocrural joint, is a synovial hinge joint that connects the bones of the leg, that is the fibula, tibia, and the talus of the foot. These are the anatomy. These are the articular surface is made by the distal end of the tibia, the medial malleolus, and the lateral malleolus of the fibula, and the body of the talus. The ligamentous anatomy of the distal tibia has the anterior talofibular ligament, the posterior talofibular ligament, the calcaneofibular ligament, the deltoid ligament and the medial side, and the ankle syndesmosis, which consists of the anterior and inferior talofibular ligament, the posterior inferior talofibular ligament, the interosseous membrane, and the inferior transverse ligament. This is the ligamentous anatomy of the distal tibia, and here is the image of the joint capsule. Now, the classification of such fractures was based on the Rudy and Algava classification, which is broadly classified into 3 types. Type 1 is non-displaced cleavage fracture. Type 2 is displaced fractures with minimal comminution and impaction. And type 3 is displaced fracture with severe articular comminution and metaphyseal impaction. This is the image of the Rudy and Algava classification of pylon fractures. Similarly, the AO classification system is a more comprehensive description of the distal tibial fractures, where the fractures are divided into 3 subtypes, that is A, B, and C, depending on the amount of metaphyseal comminution and intra-articular extension. The type 4-3A fractures are the extra-articular fractures, with subtypes being A1 simple, A2 wedge, and A3 complex. The 4B fractures are the partial articular fractures with subtypes of pure split, split depression, and multifragmentary depression. The 4-3C fractures are complete articular fractures with subtypes of articular simple and metaphyseal compression and severe comminution. This is the AO classification showing the fractures of the distal tibia. Now, the treatment modality is used. The treatment modality was actually dependent on the soft tissue conditions of the ankle region, mainly after the wrinkling, after the blisters and all the things are settled, then we went for the treatment. The conservative treatment was reserved for patients that were medically unfit for any of the surgical modalities and included cast immobilization and skeletal traction. The second option was for surgical treatments. Surgical treatments were broadly classified into 2 types. The 1-stage definitive treatment when the soft tissue condition was adequate, and the 2-stage protocol when the soft tissue condition was not adequate. This 2-stage protocol included external fixation and definitive fixation. External fixation to allow the soft tissue to heal, and definitive fixation only was done only after 10 to 12 days when the wrinkle sign appeared and the soft tissue conditions get better. And the types of definitive surgical treatment include open reduction and internal fixation by the extensile approach or the rigid fixation, external fixation with minimal osteosynthesis, that is open reduction internal fixation of fibula with external fixation and spanning of the distal tibia, hybrid ring or small wire external fixator, closed reduction and internal biological fixation by minimally invasive plate osteosynthesis. There was also option of limited open reduction at the articular region with internal biological fixation by minimally invasive plate osteosynthesis technique. Materials and method. The study was carried out at the Department of Orthopedics at LLR Institute at GSVM Medical College from January 2021 to October 2022, approved by the Ethics Committee. The study design was prospective, and here are the inclusion and exclusion criteria. Observation. We included 25 patients in our study who fulfilled the inclusion and exclusion criteria and were operated at the same institute. The demographic analysis showed that the average age of the patient was 43.4 years, and mainly there were 76% of the patients were male. Site of involvement, right-sided pylon fractures were found.
Okay, Harshit, time is up. Thank you. Dr. Abhirami.